Start on time.
Okay, I'm gonna go. Tell me when, David.
Giving a little bit of an overview for some of the recent data and some of the other indications of using SBRT in the oligometastatic setting. So I'm currently a consultant for the 1440 Foundation, which is a philanthropic organization. And then I've done some consulting work, as you can see here, and also I have research support for clinical trials. So the objective is to, as mentioned, give some terminology for oligometastatic disease, discuss some of the recent literature for using SBRT or Saber in oligometastatic disease, talk about patient selection. I think this is the part that the more that we can gain from the surgical literature in terms of, if we think about it, we now have the ability to give ablative doses to many areas, unless, of course, there's an organ at risk that's right next to it or it's invading into it. So since we can technically do it, we need to start thinking like surgeons. Which case would we resect? And there's actually a lot of literature, and I'm going to go through some of that to kind of give us an idea of how we should select our patients moving forward. I'm going to talk a little bit about treatment planning and toxicity, but again, I provided some recent references that you can look into. And then I have a little bit, just almost a personal experience on re-irradiation for pancreas cancer, as well as for rectal cancer. So this is a slide that we see quite often. And I think it's, again, this is a relatively recent field in a way. I mean, a couple years ago when I was in residency, we didn't even talk about this. And giving credit, of course, to Dr. Wexelbaum and others that have really pioneered the field. And I think the first thing I want to touch on is just the definition. Many know, but synchronous is where the primary and the met present simultaneously. This is something that you're going to want to remember for the end of the talk when we do questions. So synchronous is primary and metastatic present simultaneous, where metachronous is the met presents after the primary. In some cases, to be technical, it should be a 6-month difference, but I would say that that's not always the case. And so it was really really unique in a sense that this is an attractive consequence of the presence of clinically significant oligometastatic state, is that some patients can be put into a curative paradigm. And again, when we were training in residency, metastatic disease and a curative paradigm did not go hand in hand. So a lot of things have changed and emerged over the last couple of years in terms of, how do we look at using what's now considered a local consolidative therapy when patients present in different ways. And I think it's really complicated because it's not just patients present with a primary and a metastatic lesion. A lot of times they come to us after 3 or 4 therapies. They might have one lesion that's responding and the rest aren't, or the other way around. And so how do we put that into context? And I think what's really cool is there's now emerging data to really better categorize these patients into, so for example, if you see here, if a patient has widespread disease and they get therapy, if they have a mixed response, it's considered oligo-resistant. If they have an initial response, then if they then progress, is it oligo-persistent or is it oligo-progression? So again, it's a little confusing. I'm not going to spend a lot of time on this, but I think it's important to kind of be aware. And then the other thing here is that when patients progress after therapy, are they progressing in all sites, which would be polyprogression, or oligoprogression in one site? And again, for that's an important thing to remember for the end, is that the oligoprogression is one site and polyprogression is many sites. So I think the other thing, as I mentioned, is we don't need to start over here. There's a good bit of surgical data out there, and it's pretty impressive in a sense that we're starting to really understand the biology of how these disease occurs and how it spreads. And the other thing is, you could see here, there's a ton of literature, and it doesn't show up great here with the red, but the take home here is that there are patients that are living 5 or 10 years out after having metastatic disease to the liver, lung, and other areas. And it's across all disease entities. So the more that we can learn from the surgical data, the better that we'll be equipped to treat it in our field. And so I wanted to try to find some data on just GI. So here's a small kind of review of it's a little outdated. Actually, Tim Pollack is a colleague of mine when I was at Hopkins. And you could see that there are a good percentage of patients that are alive 5 years out with colorectal metastases. And we're not quite getting too many in the 10-year rate, but I do think as we become more and more aggressive and as therapies get better, that we'll be able to see more and more patients that are living even longer. The other idea, this is a SEER analysis that really looked at patients with esophageal cancer. And again, esophageal cancer historically just really systemic disease. But what this SEER analysis showed is that when you combine radiation and surgery in the oligometastatic setting, those are the patients that are living the longest. So we can't do this in isolation. I think that's the most important thing to convey here, is that these cases really should be discussed in a multidisciplinary setting with med-onc, rad-onc, surg-onc, and IR, and all of us putting our heads together and saying, okay, how do we get these patients to essentially no evidence of disease? And that's likely going to give us the longest survival for our patients. I think the other thing is that from a science perspective, what we're doing is being supported. So we're seeing more and more this bidirectional cell seeding. So when a patient has metastatic disease, you're seeing that the metastatic lesion can then seed the primary site and vice versa. And also, we're seeing a lot more self-seeding, and when it's seeding, the seeding tends to be more aggressive. So this supports our theory that if we're aggressive and we treat these metastatic sites to an ablative dose so that it then can't progress, that we're going to decrease the likelihood of having a more aggressive paradigm of metastatic disease moving forward. And I think, again, these are things that help you in tumor board to say, well, why would I even bother? And you could say, well, the data suggests that if we don't control this single-sided disease that's progressing, it could then subsequent seed other sites. And again, I'm not going to get into the details, but these are some literatures that, again, support the idea that genetically we can actually show this, that we could see that genetically one tumor can change. And one of my colleagues, not in here, but Chris Icabuzio has shown in patients that have undergone an autopsy that you can actually see that the tumors can metastasize so aggressively and so rapidly that if you have a tumor in the liver and a tumor in the lung, they can be genetically very distinct and very different. Whereas in other tumor types, they're quite similar. So I think, again, what we're learning is that when we're treating patients with multiple different types of cancers, we have to understand the genetics behind it and understand if it makes sense to be aggressive or not. So if we just take a step back now and say, okay, what's the benefit of doing radiation in oligometastatic cancer? It's really to be able to decrease the tumor burden and ideally provide long-term disease control. And also, as we know, the baby boomers are getting older and older, and they really don't want their quality of life to be decreased. They don't want to go through these big, huge surgeries. They'd rather get radiation if they can. And also, it allows us to continue going with chemotherapy or targeted therapies by doing SBRT. And I think that's important, too, because we don't want to lose ground, and especially when it's one lesion, for example, that's progressing. To be able to just do SBRT is much better than having to put them through an aggressive surgery. But at the end of the day, what's the literature? The literature isn't great. I mean, we talk about it a lot in our tumor boards, but it is emerging. And I'm going to talk a little bit about Gomez's paper. I'm sure Cliff is going to talk about it. I won't spend a lot of time on it, but I just also want to stress that in addition to lung, you could see that there's literature to suggest that there's a benefit in progression-free survival in prostate cancer, and also a benefit in colorectal cancer. So again, it's emerging, it's growing, and us understanding the literature so we can be knowledgeable is going to be helpful. So this is probably the strongest data to support us, and I'm going to go through this rather quickly because Cliff is probably talking about this too, but this is the combined analysis or combined study by Gomez, and it was published first in 2016, and this is where patients with lung cancer that have less than 3 non-progressive lesions continue on standard maintenance therapy, or they get local consolidative therapy, which includes surgery plus or minus radiation to the primary metastases. And the thing that's key here is the reason this enrolled so well is because crossover was allowed. So it's something to remember too. The success of these trials is often going to be whether crossover is or is not allowed. And again, it's aggressive local management. So surgery, SBRT, and/or chemoradiation to the primary site. And you can see that the earlier analysis did show a significant improvement in progression-free survival, and also there was a decrease in time to new site failure. And the area in purple should be really focused on here too, but what you could see is that there was an improvement in survival also just recently in JCO in 2019 that showed that those patients that received local consolidative therapy had a median survival of 41 months versus those who did not at 17 months. So that's an important thing to remember. So if we step away from lung for a second and now we start looking at other disease sites, the Saber-comet study is another good one to know. And in this study, again, patients with up to 5 metastatic lesions from any primary site met inclusion criteria. And again, patients either underwent standard of care, which is more of a palliative radiation, or they received Saber to areas of known disease. And again, the patients had to have, so just to make sure that we understand how these patients were selected, they had to have controlled tumor of at least 3 months. They had to have only up to 5 hematogenous metastases and a maximum of 3 metastases in any single organ site, and all sites of disease had to be safely treatable. And, I think I included this also because a lot of times we're trying to figure out what are some of the reasonable dose and fractionation regimens to treat the different areas of oligometastatic disease. And you can see here, this is kind of a nice overview of lung, bone, brain, liver. But I think the key here to remember is that normal tissue tolerance were not to be exceeded, but PTV coverage could be. And I think this is a new paradigm for us. Generally, we're always taught you need to treat the primary, you need to cover the disease, and if we go a little bit over in dose constraints, it's okay. But again, a thing to remember here is normal tissue tolerance are not to be exceeded, but PTV coverage can be. And this was presented in a plenary study. You could see that it is a mixed bag of patients. You always have to look at the details a little bit. There were more prostate cancer patients in the Saber arm, non-significant. But again, I think we still have to take it with a little bit of a grain of salt. But you could see that there was an overall survival benefit and a progression-free survival benefit in those that got SBRT compared to standard fractionated radiation. I was digging around and trying to see if there was any data to support what dose we should give metastases from colorectal metastases to the lung versus primary lung. And this is a smaller study, but I thought it was pretty interesting. It was a matched pair analysis looking at SBRT in oligometastatic lung cancers versus colorectal metastases that had gone to the lung. And it's a small study, but it did show that having a higher biological equivalent dose of 60 gray and 5 does support better control than anything less than that. So again, I think if you're going to treat colorectal metastases, and when I give the liver talk, we're going to see a similar paradigm that these colorectal metastases tend to be more aggressive and more resistant to other therapies. All right, now to switch gears a little bit, what about osseous metastases? What literature is there out there in terms of what dose we could give? Should we give stereotactic radiation? Is there really a difference? Does it matter? And so this is Quinn Nguyen's study looking at painful osseous metastasis and comparing 30 gray and 10 versus a single fraction of SBRT. And I think the thing that's important about this too is the quality of life for these patients. If they can come in, rapidly get a single fraction of radiation and get home, there's a lot of value here, and this is a really important study because it actually is teaching us whether it's valuable or not. And it was recently published. It did include a mixed bag of patients from lung, pancreas. You could see a lot of it was lung, but just to kind of be aware. And you could see here that with stereotactic radiation, there was local progression-free survival of almost 100% essentially, compared to only 75% as it progresses over time in the standard fractionation regimen. So not only is the quality of life better for these patients, but again, the control rate was also better. And here's a couple examples of, this is a standard 16 gray SBRT plan showing to a bony rib lesion. And then also here's a 12 gray single fraction SBRT. And again, I think that the larger tumors here, generally you want to give around 12 gray to, and the smaller tumors want to focus more on 6. You can give a higher dose as long as the OARs are maintained. And this is just a quick example, a case study just showing that this patient presented with urinary incontinence, loss of sensation, and after the single fraction of SBRT regained urinary sensation and function, removed the catheter, and really, even over just a couple weeks after the radiation. So what else is out there in terms of other sites of disease? So this is another study done at MD Anderson by Dr. Nguyen, again, looking at oligometastatic disease in esophageal and gastric cancer. And this is very similar. Again, patients undergo standard chemotherapy, and then they're, again, similar paradigm to lung, where they're then randomized to standard maintenance chemotherapy or to early local radiation therapy plus or minus surgery. And again, this is ongoing. And then the other thing I wanted to look at is what else is out there in terms of toxicity and quality of life. There's not a lot out there. People obviously say it's better quality of life, but is there really clearly a trend? So I was able to get, Dr. Heron was kind enough to share these slides with me. These are looking at quality of life and their sort of similar trial where they treated patients with multiple sites of disease. Again, this is oligometastatic disease, multiple sites, and again, defined as 5 or fewer. And you could see the inclusion criteria was less than 5 metastases and less than 3 organs. And this was, again, also a mixed bag of different sites. And you could see very similarly, they clearly defined exactly what dose patients would receive, whether it's CNS, lung, adrenal, bone, et cetera, and also what the standard PTV expansions would be based on the area a site. And they said in general, preference was given to 60 gray and 4 fractions when possible. And again, it was a mixed bag of patients, with most patients being lung, but you could see that there's a lot of patients with other sites of disease. And in general, you could see that these patients did well, that colon and rectal tumor patients had the best survival in their group, and even approaching 50 months in these cases. So again, just amassing more data to support the value in these cases. And then if you look at the total FACT-G, so FACT-G is more of the global quality of life analyses, you could see that after radiation, it's not significant, but there's a trend towards an improvement in quality of life in these patients, and the toxicity rates are really single digits. So when you're in a tumor board setting, again, you can say not only is there good data to support local control, there's emerging survival benefit, toxicity is low, but also there's prospective quality of life data suggesting that patients are getting better with time. But if we switch gears now to what about some of these other sites like pancreatic cancer? A lot of people will say, well, why bother? Patients with pancreatic cancer are going to die anyway. At least with colorectal cancer, we know there's really good data with surgery. What about in other settings? And so I think first of all, we should extrapolate what have we learned from colorectal cancer? And what can we learn with respect to the morphology, the patient characteristics, and what are the high-risk groups? So if you look at some of the early surgical data for colorectal metastases, these are the patients that would typically, they would break it down into a low-risk group and a high-risk group in terms of trying to decide, should we resect this or not? And I think as we emerge as a field, we want to kind of approach it the same way. We want to say, okay, should I radiate this patient with metastases or not? And so looking again at biomarkers that are available, so CEA in this case, or in pancreas cancer, obviously CA19-9, looking at the size of the liver tumor, et cetera. And then also, in addition to that, just trying to understand what was their stage at diagnosis, how bulky was their disease, is there really going to be value in me treating these cancers? In addition to that, we now are in the genomic era, right? We have a lot more data in terms of what are the genetic mutations that are available. And you could see here, again, whether it's RAS, this is some really great data by Nick Voté out of MD Anderson, and there's, and also by Dr. Chun, but looking at, P53 status, RAS status, et cetera, and the intermixing of those really help us understand which patient should we aggressively treat with SBRT in the same way that the surgeons are trying to use this data in terms of who they should resect. So when I published this back in 2015, which is 6 years ago now almost, people thought, again, we were crazy. Bob Wolf and I were saying, are there patients that we should really, with metastatic pancreas cancer, that we should consider treating and taking care of them in a way that is more aggressive in the stage 4 setting. And this is a paper that we published in 2012, and I think this is kind of just a real quick overview, is these are patients that had surgery for pancreatic cancer, and then we looked at them over time and looked at patterns of failure. And what was very clear is that if we could debulk disease earlier after surgery, so as soon as we see a local progression in the lung, liver, or otherwise, if we could debulk the disease based on mathematical modeling, we can decrease subsequent mutations from occurring, and ideally we could decrease systemic progression, and then these patients should, by definition, live longer. So it was a bit thought-provoking, but again, at least supported the idea of being more aggressive earlier with metastatic disease or with progression. In addition to this, you could see that in some patients, it's small, these are really small studies, but in patients with pancreas cancer that have liver metastases, if you do resect, some patients do live longer. So how do we understand which patients we should resect and which ones we shouldn't? Which ones should we do radiation? Which ones we shouldn't? And I think the other thing too is that people think that with lung metastases for pancreas cancer, again, there's no value in irradiating these, but in actuality, you could see that in patients with isolated pulmonary metastases that have surgery, there is a flattening of the curve. It's small numbers, but again, in the right patient, it's probably reasonable to still even treat with pancreas metastases. And then finally, we just know with the recent literature, recent publication mutations that do receive a platinum drug tend to do better. So if patients are on a platinum drug and really doing well, and they have a single liver metastases, that's probably the patients, or patients that have BRCA mutations, those are the patients we probably should be aggressive with in the oligometastatic setting. So the next thing is that there's all these studies that are now emerging, basket trials, umbrella trials, and I think it's important that we, again, understand the literature, that we understand the difference. So this is an important thing to remember, that a basket trial is generally trying to take multiple disease sites, and you're either testing a single treatment, or you're looking at a single mutation, et cetera. So again, basket trial, multiple disease sites, looking at a single option of treatment. And the example of this is an extend trial. This is Chad Tang out of MD Anderson. It's kind of a novel approach where patients with all of these different histologies, if they have less than 5 metastases, they actually, well, the first part of this arm is they actually go ahead and they get either radiation, surgery, IR. You can get anything to get you to NED. And then depending on the outcome or how fast they accrue, there's then baskets where patients are then randomized to standard local therapy or standard systemic therapy or local therapy. So the thing that's cool about this is it really allowed us at MD Anderson to open the door and look at oligometastatic disease in all of these disease sites. And now we're going to now branch it down into smaller baskets to be able to see, is there truly a benefit in specific disease types? And this is just this is an example of a patient, 66-year-old woman with pancreatic cancer, showed a mass in the tail of the pancreas, had a staging laparoscopy, FOLFIRINOX times 6 months, had 2 liver metastases that were relatively stable. And so in this case, this is an example where we gave 70 and 10 to both of these areas of metastatic disease. Patient had literally no toxicity from this and has continued to remain NED. So in the last couple minutes, I'm going to talk a little bit about just how do we approach these from a treatment perspective. What are the things we need to think about? Some of us have 4D, some of us have MR guided therapy, some of us have 4D not everybody has all the toys at their disposal. So how can we be creative in terms of managing these? So first and foremost, even if you don't have a PET sim, I do think it makes a lot of sense, if you can, is to get a PET scan before you treat these patients. What I have found is that a lot of times I would treat them, and then they go on, and then they get a PET scan by the medical oncologist, and now there's more disease. So again, staging these appropriately. If you have the benefit of having a PET sim, obviously that makes it easy from an integration perspective. The other thing is the information from this. I'm trying to figure out how to use this. I don't know if it's going to work. Nope, it doesn't work. Is that even if you don't have 4D, you can do inspiration, expiration, obviously create an ITV, and then you're going to add your margin. When you're treating all these oligometastatic sites, you also want to think about if it's breast cancer or colorectal cancer or melanoma, they're going to live longer. So you want to always think very carefully about, if I radiate this, if I have to come back and radiate something nearby later, what do I need to maybe do differently, or how do I actually approach it? So for example, I'm going to talk about this later, but in liver metastases, ideally, if you could treat and spare all normal parenchyma and even go to more even like a more conserved field where you're not spreading dose all over the normal parenchyma. So that's like, for example, a central lesion, proton therapy can be awesome because it allows you to give very focal radiation with sharp edges, and you're completely sparing sort of the contralateral or the adjacent liver. So really just thinking through it and making sure that you're trying to spare dose as you move forward. And you could see that, again, having more technology at your disposal is going to give you more information and allow you to cover these lesions. Because you could see in this one, the small nodal region that's just outside the primary tumor, with standard CT, you might not have seen those, and you would have had a near miss. So the data can really, and or MR can make a difference. All right, so as far as, I guess I just wanted to kind of give you a sense of what are some of the new trials that are out there, just so that you have something to stand on. This is a non-small cell lung cancer. I'll leave this to Cliff, but the core trial also includes prostate. The Oriole trial was done by Phu Tran at Hopkins. I actually treated a few patients on this trial when he was on vacation. And this is patients that had prostate cancer with less than 3 metastatic lesions, less than 5 centimeters, were hormone sensitive, and then basically would give SBRT to all sites of disease, similar to what has been done in the lung literature. And you could see here that if you do Saber in these prostate patients versus observation, that there was clearly a progression-free survival benefit. And a follow-up sort of to this trial is the STOMP trial, which is going to be looking at this more in a randomized setting of patients. If they have polymetastatic disease, they go on to just androgen deprivation therapy. If they have oligometastatic disease, they get randomized to radiosurgery, radiotherapy or surgery, or active surveillance. So I think it's cool that there's a lot of these trials that are emerging to allow us to have a way to understand how we should treat these or manage these. Also, the other thing is these patients don't always just come on chemo, right? They're coming with targeted therapies, on immunotherapy, and I could give a whole talk on this, but I think that this was helpful, that this is a study that showed that you can give TKIs while you're giving SBRT, so it is safe, but again, you need to just be obviously mindful of that and careful. There's a ton of data evolving, and I'll talk about this a little bit more in the pancreas talk, but how radiation can induce immune effects. So radiation can bust up antigens that allow our bodies, so if we're on a checkpoint inhibitor, it may make tumors that are typically not immunogenic, make them more immunogenic. And I think we still have a lot to learn about this in the oligometastatic setting, as why is obstacle pole happen sometimes but not at other times. So if we pull it all together, we have to then think about all these factors. So we got to be aware of all the different, patient selection, identification, size, dose selection, toxicity. How do we integrate and time systemic therapy? Personally, I usually try to give at least a week or 2 off before giving radiation in these settings, just to be on the safe side, but I don't think we really know. Some people believe we should give the radiation early and then systemic therapy. Other people think we should do systemic therapy, then radiation, but there's a couple studies emerging to look at this. But I just listed here, with lung, you need to be careful about central tumors, which I'm sure Cliff will talk about a little bit more. Be aware of rib fractures, chest wall. In my area, it's really bowel perforation, the stomach, being aware of what the small bowel moves a lot, so you have to really be aware of that and make sure you give enough margin. Skin toxicity in some cases for very peripheral regions, and then also patients that are on VEGF, they can get fistulas. Rather than go through all the toxicities, I found a couple things in immunotherapy. This is a nice review on SBRT and immunotherapy. And then this next one is a nice consensus on normal dose constraints. Mostly, I typically, we have our own MD Anderson constraints, the Timmerman, and then the NRG LU002 study is another good one as a reference, and I added it here to look at some standard dose constraints that you could use. This is another one that, Palma put together, the 4 ACEs. So these are the kind of patients that you typically are going to want to treat, and some of the common definitions. And again, I'm not going to go through this in detail, but this just gives you sort of, again, an idea of what types of patients you typically are going to want to treat in the oligometastatic setting. So where is it going? And I think we're getting to a point, and this is already being done. Dan Gomez talked to me about this at Sloan Kettering, of having multidisciplinary clinics for just oligometastatic disease, where you literally say, okay, this is a patient that's been pretty stable and now has a couple lesions, and then you would bring everybody together and then decide how you're going to treat these patients. And again, these are all the factors that you would want to think about as you're trying to decide whether or not you should treat. Are there data to support treating it or not? And then how do you kind of manage these patients moving forward? So in the last couple minutes, I'm going to just switch gears now and talk about pancreas cancer and recurrent disease. A lot of times I get an email or a phone call and say, I have a patient that I treated to 50 gray and or I did SBRT to, and now it's progressing. Can I safely treat this area? Or this patient had a Whipple and they have this huge local recurrence. Is there value in treating it? How would I treat it? What's the best way to approach it? And this picture I think is very telling. If you want a good picture, let's say you have a patient that had surgery and has a margin positive resection, and med-onc and surgery are like, we'll just give chemo. It doesn't matter anyway. This right here is I don't know if this works if you touch it. It does work. That's pretty cool. Okay. This is what a local recurrence looks like in a patient after surgery. There is nothing you can do here. This is palliative. I mean, you're really not going to resect that. If you irradiate that, I mean, it's unlikely to work. So in a patient that has a high risk, especially a young patient, I still think there's a role in giving adjuvant radiation, especially in high-risk patients. And I think this is a good picture to show people that this is why you should do it. Also, when I was at Hopkins, I had a really smart resident, Avni Rao and Rachit Kumar, that did this really cool analysis where with radiology, we looked at where exactly do patients recur after surgery for pancreatic cancer. And you can see the different colors are just whether they got neoadjuvant or not, et cetera. But the take home here is almost all the recurrences happen right around the celiac or right around the SMA. So again, when you're thinking about if you're going to give stereotactic radiation or you're going to give high dose radiation, let's say it's an R2 resection, if you treat the primary tumor and maybe 4 or 5 gray to the surrounding region, typically you're going to encompass this. And I have a prospective trial looking at stereotactic in the adjuvant setting that I'm in the process of submitting here in the next week or two. But what about if the cancer has come back? Can you re-irradiate? So I had a prospective trial at Hopkins that allowed us to give another 5 gray times 5 after patients got 50 gray previously. And the 50 gray could have been given neoadjuvantly or adjuvantly. And what we found is that there are a couple features that define whether you should even do it or not. So in general, if patients had progression-free survival of at least 9 months after their last radiation, those are the patients where I think it makes sense to do re-irradiation. And also, if you're going to re-irradiate, ideally you want to give maintenance chemotherapy. And I think it might be because when we irradiate, we might be busting up the cells, et cetera, and can cause systemic progression. So keeping them on something systemic and also just to help control the disease is beneficial. If they're not healthy enough to get maintenance chemotherapy, it may not be beneficial to give them the radiation unless it's truly for palliative purposes. The other thing I'll just say is that we're learning that you could probably give higher doses. So if you have MR-guided radiation and you could really hone in on the area and you can really in real time visualize motion, et cetera, and there's no normal bow around it, I think you can safely start pushing up to another maybe 7 gray times 5 or even 15 fractions to 45 gray. But there's not literature on this, but I think we need to go higher if we're going to get a longer-term local control. And the thing that's cool, though, is I would say there are some patients that lived longer. So again, I think there's value in considering this in patients as opposed to just keeping them on chemotherapy for a long time. And here's an example of looking again at the survival curve. As you can see, the maintenance chemotherapy was a big one. If they didn't get any maintenance chemotherapy, they did not do well. So they should be able to get maintenance therapy. And you could see this is an example of one of the re-irradiation stereotactic fields that we delivered in this study. I knew I wouldn't have time, and this is perfect. I'm pretty much on time. When it comes to recurrent rectal and anal cancer cases, I think the most important thing to consider in these cases is, can they get surgery? If you have a patient that got 50 gray for rectal cancer or 60 gray with anal cancer, giving them another 30 gray or even doing 1.2 BID to 40 gray, et cetera. And Emma Holliday has a nice study. I didn't put it in here, but they don't do great. The reality is they don't do great. So in general, the best way to help these patients is have them see a surgeon where they have intraoperative radiation therapy. If you don't have it at your institution, I think the right thing to do is have them see a surgeon where they have IORT, where you can essentially give another 30 to 36 or even 40 gray in Q-day or BID treatment, and then let them get surgery and then do IRT. That's the only way to get them to a BED that is roughly equivalent to what you need to sterilize microscopic disease of about 50 gray. So again, I think that if they don't want surgery or they're not surgical, I think you could safely do like 36 and 2 gray fractions with IMRT or 1.2 BID up to about 40 to 46 gray, but it's not going to be very durable. Ideally, giving them pre-op radiation, surgery, and IRT is going to give them the best long-term control. So in summary, there's strong clinical and translational rationale for considering local therapy for oligometastatic disease. Treatment of oligometastatic disease is feasible, and it does appear to improve quality of life, and toxicity is low. There's a huge learning curve, though, and we need to select patients better. And also, in general, PTV should be compromised to keep it safe. The better technology that you have, the better to be able to treat these patients more effectively. The future is really combining with targeted therapy, immunotherapy. Re-irradiation is still a little tough, but also there's another thing is that looking at, there's a lot of radioprotectors that are evolving better than amifostine that I think are going to allow us to treat to a more definitive dose moving forward. So thank you. And then Sam's, right? I'll go fast. I think we're doing okay on time, right? Okay, cool. Being first, I didn't want to push us back too much, so I think we're okay. Take your time. Any questions while pulling up the SAM questions? Oh, can you speak into a microphone? I don't know if there is one. Here you go. Let's see. Yeah, go ahead. I'll repeat it. I can repeat it.
So what's the probability of your insurance covering SBRT, i.e. IMRT, for bone metastasis? How many hours a day do you want to spend on peer-to-peer?
Well, I guess it's a very good question, and I think it comes down to, maybe I'll answer it in a different way, because I was not the PI of that study, and I actually didn't have to fight too many on that. I didn't treat many patients on that study. So I guess the other way to look at it is, for pancreas, let's just say, for example, I would have peer-to-peer with every single case for the first several hundred patients I treated. Yeah. And even though there wasn't great literature, it turns out that SBRT actually was cheaper than doing chemoradiation with Xeloda. And also
3 and 10. Or
I got you. But I'm just saying, from a quality of life perspective, cost, out-of-patient cost, there was definitely, that was an easy sell for me. I think in the bone met, I think what it comes down to is right now I think it's going to be tough. I think it has to be done ideally on a clinical trial, but I would also say that in the right patient, that there's an argument for it, especially patients that maybe live far away from a radiation facility and they're going to have to stay in a hotel for 10 days. So I think that there's certain aspects that we should take into account when we're talking to our insurance companies about the value of it. And also I think the one argument is if you see the local control benefit, again, small numbers, but it's pretty convincing that there's a split there in the curves. So as more data emerges, and I think as our technology gets cheaper, as it gets better, maybe that would be the argument. But again, I'm open to the audience. So maybe Sue can go ahead.
Well, I was going to say,
I got one more question for him.
We're friends.
yeah, very friendly. Hi,
Hi, Joe. So we've actually fought that battle somewhat successfully with
Okay.
some of the spine SBRT cases. I mean, I think when you're in spine, SBRT is a lot more acceptable, even bone. And then the other argument we've made somewhat successfully is that if patients are on systemic therapy, there are really unknown toxicities that come from the combination. And so, frankly, I don't think we completely understand that, but there's cases where I think SBRT really may be more substantially safe, especially talking about cases like the bowel. I mean, I do that every once in a while on a blue moon, and it's pretty scary. So
Yeah, I would say for
So-
pelvic metastases, especially with patients on checkpoint inhibitors, there's a much higher risk of GI toxicity and such.
I mean, I had one last question.
Sure.
And that is, as you pointed out, it looks like for the oligomets, we're aiming at better quality patients, higher performance status,
Correct.
younger, fewer mets, controlled primary. So if you go and you radiate a weight-bearing bone, what's the risk of pathologic fracture in a year or two with the high dosage you give with SBRT versus giving 3 and 10 or a more conventional fractionation? Do we know?
I don't think we do yet because we haven't followed those patients long enough, but Mohammed?
Let me
You wanna do the
just say,
questions?
Astro is about to come out with a white paper on SBRT, which I think will probably help with insurances because it talks about the studies. So that'll help. And then also, at least in the GYN, NCCN guidelines, we
is it?
just added a paper, and for oligometastatic disease, consider radiation therapy with SBRT. So at least for GYN cancers, that'll help. And then I think Joe, Dr. Herman, aren't you on NCCN? So if they start to add those to the NCCN guidelines with the papers, that should also help with insurance companies. So hopefully in the next year or so, as the data is coming out, it'll help.
I have trouble getting IMRT approved for small cell lung cancer conventional treatment.
Okay.
I had a quick comment also, hopefully to help, is I think we're moving fairly rapidly to bundled payments for radiation
Yeah.
oncology. So that would go away. I think the best thing is to do what's best for the patient. Exactly what Joe's talking about. Look at the trials. Look what will ideally treat our patients. When you go into a bundled era, we're going to decide what we want to do and how we're going to do it.
Well, I guess half of us, 40% of us in March, we'll find out,
Yeah.
right? Woohoo! Okay. So we're going to do the SAM quiz. Everybody have their clicker? All right. Got mine too?
As he just said, you might have heard. We're going to read the questions, read the answers, and there's a 10-second delay. And don't forget to use your clicker, obviously. Is that good enough? Yeah. Okay, cool. All right, and this is where I read. Okay. Which of the following describes a case where a patient with pancreas cancer presents with a primary pancreas tumor? Now, I know this is hard for early in the morning, but I think it's, if you follow here, with a primary pancreas tumor with 2 liver metastases, so present at the same time, who receives targeted therapy and then develops several new lung metastases with no progression of the primary tumor. So the options are, so again, you're breaking it down to synchronous versus metachronous, and then is the systemic progression, so again, I'm not going to, should I read the questions too, the answers? Sure. All right. Synchronous oligometastatic disease and systemic oligoprogression, synchronous oligometastases and polymetastatic progression, metachronous oligometastatic disease and regional oligoprogression, or metachronous oligometastatic disease and polymetastatic progression. Okay, and pick your choice. I tried to make it easy, I don't know. And Cliff will make sure I actually did this right. You can comment if I did something wrong. Okay. Okay. All right. Yeah, I mean, I guess the way that this is emerging, so again, Cliff, maybe I'll have you kind of chime in here too. But as I understand it, that this is systemic oligometastases and it's systemic oligoprogression. So you're still progressing in one region as opposed to multiple regions. So therefore, the correct answer should be A. Okay. All right. Okay. Several versus many? Okay. All right. The rest should be easier. That was a tough one. All right. in the
Sam
study-
credit if you still get Sam credit if you miss one.
Yeah, all right. Okay. In a study by Gomez et al., 2019, which of the following describes the overall survival months for stage 4 non-small cell lung cancer who received radiation plus chemotherapy versus chemotherapy alone? And this is that number, that higher number that we talked about, like at the pinnacle of survival. So go ahead and make your choice. Actually, it's weird
Sure,
now
it
that
turns green when you press the answer.
all right, there's one person that still needs a little more coffee. Or a couple that need a little more coffee. Okay. All right, it's pretty straightforward. That was the study did show a 41-month median survival compared to 17. All right. In the study by Nguyen et al., which of the following dose fractionation regimens result in a significant improvement in progression-free survival for bone metastases when compared to standard fractionation for a tumor that is greater than 4 centimeters in size? So when you have a large tumor, especially if you're close to things, you're going to want to be a little bit more conservative. So 25 versus 20 versus 16 versus 12. And again, greater than 4 centimeters.
And the other thing to point out is we have 18 SAMs, more than enough to get you through 3 years. So.
All right. Okay. All right. And I think, again, the key here is that the 16 gray was used for the smaller lesions, 12 gray for the larger lesions, and that was just part of the actual criteria of the study. Okay. All right. Which of the following defines a trial design where a new drug or treatment is tested on patients with several different diseases or histologies? All patients get the same treatment or have the same biomarker. So one basket trial, so multiple baskets, or an umbrella, a single umbrella, a Simon two-stage, or a platform trial. And this is the extend trial, kind of that I'm talking about. It's a basket trial where you have multiple. I'm trying. All right. And so, again, just the key here, I think, is as radiation oncologists, we have to speak the same language as our medical oncologists. So it's a Simon two-stage is just a statistical design that's typically used for phase 2 trials to pick the winner. And then a platform trial is very common these days where we're trying to essentially look at, we have one single control arm, and then we have multiple different sort of regimens that so kind of like TNT is a good example of that for rectal cancer. So where we're doing a platform, and then as mentioned, an umbrella trial is sort of where you're looking at one disease site, et cetera, as opposed to multiple, okay? And then, in the Saber-comet study by Palm et al., a patient with liver metastases is treated as 60 gray in 5 fractions. Per the protocol, which of the following is true? All right, so this is the study that, so which of the following is true? The protocol allows up to 20% hotspots of the bowel. The protocol allows compromising of the PTV in order to not exceed normal tissue tolerances. So it allows you to not, again, the key is to not exceed, and then you can underdose the PTV. The protocol allows for standard fractionation regimens, and there was no significant improvement in progression-free survival. Which of the following is true? So I think an overall theme is we always want to be safe. All right. We ended on a strong note. All right, thank you, everybody, and enjoy the rest of the day.
Okay, thank you, Dr. Herman. And because I kind of missed my cue because I was loading talk. So he has both an MD and a business degree, started at the University of Maryland and then went to the University of Michigan, go blue, and then was at Hopkins and is now a professor at MD Anderson, specializing in pancreatic, hepatobiliary, and SBRT. And now we have Dr. Cliff Robinson, who started at Case Western and then did his radiation oncology in Cleveland. He's currently at WashU, and his specialties are brain, thoracic, neuro, and I would say cardiac, one of the innovators of cardiac, and he is the chief of the SBRT program there. So welcome to Dr. Robinson. Around here. Anybody else have any questions about anything? We do have an orthopedic surgeon in the audience. Hey Arnie, do you know like what happens to the bone when we do really high dose focal, or how you would decide when it needed to be pinned? No. Okay. We will find out. The literature is early.
If anybody did not get their little thumb drive syllabus, we've got enough now for everybody, so let me know and we'll make sure you get one.
I'll just pocket it. Yep. Sounds good. Okay. Let me know when you're ready. Okay. Okay, great. Thank you. And thanks for kicking off the meeting with a great start, Joe. So again, my name is Cliff Robinson at WashU. I really appreciate being here today talking about cancer for once in a while. The last 10 lectures I gave, actually, I just realized we're actually all on treating cardiac VT with radioablation. And so this is nice to actually go back to what I was trained to do. Again, we're going to start out, we're going to take a little bit of a change of direction here. We're going to talk about locally advanced non-small cell lung cancer. My oligometastatic discussion will be tomorrow. We didn't want to give you back-to-back oligomets. That would be a lot for a morning. Here are my disclosures here. And I guess maybe one of the more important disclosures is that I run in some tight circles of people who do similar talks, and so we've gotten in the habit of swapping and trading slides like they're trading cards. Here are some credit where credit is due. I think importantly, though, we just need to start from some of the basics because, again, some of these things are really critical to moving forward when we think about managing these patients. At the end of the day, some of these stats have sadly not changed that much over the years. And importantly, lung cancer remains the second most common of the cancers that we see in both men and women, but yet remains the primary driver of death, and that has not changed in many, many years. So as we think about all the fancy tools that we have, and we think about all the new drugs coming out, at the end of the day, what we should still be doing is thinking about how to prevent this, because prevention is overwhelmingly more powerful than treatment. And smoking is the single most important risk factor. So when you're seeing your patients in clinic, this is still a valuable discussion to have. I think there's a reason why this is the kind of thing that ends up in things like APEX accreditation, where they want to verify that you're talking about this with patients. I would say it's probably worth mentioning, though, that there is a little bit of a landmine here, because while having smoking cessation discussions is key and important to trying to prevent cancer, and certainly we want to reduce the nihilism that's associated with a lung cancer diagnosis where they say, oh, shucks, I got lung cancer, smoke them if you got them, what's that going to do? It turns out actually that quitting does still help. But there is a little bit of a landmine there because there is an increasing proportion and an increasingly more vocal proportion
of non-smokers or minimal smokers, particularly those who have driver mutations. And so you can get into a very, very kind of scary conversation where where it becomes almost punitive. You know, oh, you brought this on yourself. You know, you smoked. This is what's happening. So be aware of particularly some of these people as they come in. You know, some of these younger women with EGFR mutations where there was no smoking involved, and so a smoking cessation discussion for that person could be kind of patronizing. I may have stepped in that once or twice, so that's why I'm mentioning it to you guys. I think the other thing too is that, you know, screening. So screening is always a controversial topic. You know, there's a lot of resources that go in to getting imaging or maybe in the future blood-based biomarkers. And so you want to prove not just that you can diagnose the cancer earlier, but that it actually matters. And so we've had these discussions now for breast cancer for many, many years. And certainly, you know, that's several lectures unto itself. But I think in the lung cancer world, we finally have evidence that low dose, high resolution lung screening CT will find more lung cancers earlier and prevent lung cancer death. And in fact, depending on how you play with the numbers, there's a 20% relative reduction in lung cancer mortality from low dose CT. The absolute numbers, whenever you look at any screening study, will always look less impressive. But I think there is tremendous value in trying to integrate your patients into these paradigms, and if your institution isn't already doing CT screening, it's certainly worth talking to your radiology group about it. But you know, if we can't prevent it and we haven't screened for it and found it earlier, what should we do for these patients where they do present with locally advanced disease? And I think just as a general reminder, always going back to the basics, whenever possible, they'll always benefit from a CT of the chest, abdomen, and pelvis with IV contrast. A PET CT is critical in 2020. And a brain MRI for anybody with locally advanced disease is important because the occult risk of brain metastasis, depending on the histology and the stage of the disease, is well in excess of 10 to 15% in most studies. Whenever you're biopsying these patients, I think the preferred approach is to kind of maximize value. So if you can both prove that they have nodal disease and get a tissue diagnosis, that's going to be your best bet. So an EBUS FNA of the nodes, whenever possible, is great. You know, particularly if there is ambiguity in the lymph node involvement, just doing a CT-guided biopsy of the primary can be a problem because then you don't know whether the nodes are actually involved. I list here the molecular testing, and Dr. McGarry made me promise that we would not talk about all the different mutations today, so I promise that I won't do that. But it is worth noting that while none of these mutations today are relevant for the management of patients with locally advanced disease, it seems inarguable that they will likely someday become important because they're vitally important for the management of metastatic disease. But I think what's also really exciting is the notion of liquid biopsy. So what you may have seen in your clinics now is particularly patients with more advanced metastatic disease that you may not even need a tissue diagnosis per se. You can actually get it from the circulating tumor DNA. So on that notion of PET scans, this is why it's so important. So not only is a PET important because we know already from many older studies that you will find more advanced disease, find more distant disease, find more regional disease, but the timing matters as well. And this is one of many studies that have shown that the older your PET gets, the more likely you are to miss progression in the interim. And it may be as little as 5 to 6 weeks. Now, I know this poses a major insurance hurdle, and I'm not immune to it as well. Certainly, if you have somebody who comes in with a 6-week-old PET, you may just have to deal with what you have. But certainly if somebody has a 4-month-old PET, that is an inadequate staging assessment for that lung cancer patient because they have at least a 1 in 5 chance of having upstaging in the interim. And part of what we look at on these scans, of course, is the nodal stations. I'm not here to quiz you about all the nodal stations. I do think it is important not to know them, just to memorize them for board's purposes. But they are relevant, particularly when thinking about post-op radiation, which we'll talk about in a second. The important things to remember is that there is an official nodal staging atlas that comes out with the AJC staging manual. I think there is a better radiation oncology friendly atlas that you can see here. So this is published in Pro in 2012 from Dr. Lynch and others. And this kind of shows how you actually go about in real life contouring these nodal stations for patients, particularly when thinking about post-op radiation, less so for locally advanced intact patients. One of the minor things, and again, this is kind of a subtle thing, but in the staging manual, one would think that the midline of the patient, when differentiating between somebody who has contralateral or ipsilateral nodal disease, would be in the center of the trachea, but in fact, somebody thought better of that, and it's actually technically to the left of midline. This ends up being a subtle thing, but certainly when you're staging a patient and deciding whether they have N2 or N3 disease, it can matter. The other thing is that, and I put this in here somewhat tongue-in-cheek, but I probably have reviewed 500 or more cases through the RTOG as part of our peer review for various clinical trials over the years. And one of the most common things I see is contouring pericardial recesses that are filled with fluid as lymph nodes, and I'll show you a picture here. So the pericardial recess is a normal anatomic structure that occurs as a function of the way the pericardium attaches to the outside of the heart and the mediastinum. And so you can get these fluid-filled spaces, and there's normally 15 to 30 mLs of fluid here, but you can see sometimes they can show up quite rounded as well. But what you'll see is that they're very uniform in Hounsfield units in density. That's fluid density. That is not tumor density. But I commonly see something like this contoured as a lymph node, and admittedly it can be very tricky. The PET might even be mildly hypermetabolic in that area. But really, if you compare it to a tumor, I mean, tumor is a tissue density, tends to be more irregular, have soft tissue attenuation. And so this is just one thing to kind of look out for as a hurdle. And as I think was said, bets, it's not a tumor. And then the other thing, again, I am not a fan of memorizing staging manuals. I don't think there's particular relevance in that. I do think it is worth mentioning, however, that every time we do an iteration of lung cancer staging, we end up kind of splitting more away from the median. So we have, here's an example for locally advanced patients, where essentially the tumors that used to be classified as a large T2 are now being upgraded into the T3 category. So the 5 to 7 centimeter tumors have now been shifted into T3, and the even larger tumors are shifted into T4. And part of this only really matters as it relates to the notion of whether we might consider to operate or not operate on these patients, because unfortunately for locally advanced lung cancer, there's it's kind of a tremendous wide paradigm in terms of how you can manage these patients. So I'll largely think about these, limited N0, N1 patients as being the quote operable patients. These borderline N2, so single station nodal involvement, maybe limited burden of nodal disease as being potentially operable. And then the patients who have more advanced disease as being the more classic inoperable. So kind of stating that another way, if you were to look to the NCCN for guidance, what you'll find is that it allows you to essentially do whatever you want, which is not terribly helpful guidance. It's essentially, it does verify how you should stage the patient, but essentially once you get to the point where you've demonstrated that they don't have, quote, metastatic disease, they can have anything from induction chemotherapy, induction chemoradiotherapy, definitive chemoradiotherapy. And so I want to kind of walk through how you might think about some of those decisions. So again, there's various ways to get to stage 3. So one way to get to stage 3 would be to have a patient who has earlier disease, maybe stage 1, 2, and then they go to surgery, and then they have so-called surprise N2 disease, meaning, surprise, you have N2 disease. I don't know who came up with that term. But you basically have, on pathologic staging, you'll have evidence of higher nodal disease than you thought. These are the patients where there's significant systemic therapy data that shows that there's a small but significant improvement in overall survival with the use of cytotoxic chemotherapy like platinum-based chemo, and then controversial data as to the use of post-op radiation. I'll talk about that in a second. The other paradigm, which has been very popular in certain institutions, is to take these patients who have, again, kind of borderline operable, possibly operable, locally advanced disease, give them induction therapy, which has historically been chemotherapy, and then follow that by surgery, plus or minus post-op radiation. And then, of course, if you're the last way to consider trimodality therapy would be full-bore definitive chemoradiotherapy followed by surgery, which is actually kind of falling out of favor in general. Now, the new kid on the block is immunotherapy, and we'll talk more about this in the context of definitive chemoradiation, but I think it's worth mentioning that this is something which is technically competitive to our arm of managing these patients. There are now several studies, and I think the Nadim trial is maybe one of the most impressive, that looked specifically at induction, chemotherapy, and immunotherapy. So in this case, this study took patients with potentially operable stage 3A non-small cell lung cancer. They got induction nivolumab and chemotherapy. So nivolumab is a kind of a first-generation anti-PD-1 checkpoint inhibitor. And then they went to surgery, and then they were allowed to get some adjuvant treatment. And I think impressively, and this is kind of unparalleled, never before reported, 90% of those patients had downstaging, and that's significant major pathologic response. Again, 90% patients have downstaging. I know it's not a radiation question, but it seems like it could be a good one anyway. 90%. All right. But this is important because in our tumor boards, you know, our surgeons are pointing to this data and saying, well, what do we need radiation for? We'll give some immunotherapy and then we'll cut it out. Now, having said that, if you do have surgery and you go through any one of those modalities, as long as you didn't have radiation in the upfront part of it, and you find surprise N2 disease, or you find pathologic disease in the specimen, what about the use of post-op radiation? So the historical, kind of widely cited, the quote, you know, the PORT data, the PORT meta-analysis, rather definitively told us that if you use large fields, high doses, somewhat indiscriminate use of OARs, really no concept, a lot of it 2D, early 3D treatments. There is no survival advantage to PORT. In fact, actually, there's quite the opposite. There's a survival detriment to the use of post-op radiation. And I think that's the beginning of a theme that we're seeing in the management of lung cancer, which is this constant battle between trying to get tumor control while avoiding adverse events. And I'll kind of speak to this as we go through this for the definitive patients and then more later on in a specific talk just talking about cardiac toxicity. But what about more modern treatment? So a little self-citation here. So we're one of many groups that have looked at databases, and so we looked at this National Cancer Database several years ago when it was kind of the cool thing to do, to look at all these databases. And we looked specifically at patients who had rather clean, just pathologic N2, so they had resection, pathologic N2 found in the specimen, and then they were given chemotherapy, so they were given best standard of care vis-a-vis 2000s treatment. And then we looked at whether or not those patients got post-op radiation or not. And again, these are modern patients who specifically had, more kind of standard treatment the way we would think about it today. And there was, again, a small but real survival advantage in those patients. Retrospective data. So with that being said, what we want is prospective data. There is a trial that's completed accruing in France. It's called the IALT trial, or IART trial, sorry. Again, this randomized patients to post-op radiation. Those results will be coming soon. In the meantime, if you have a patient who shows up who you think would be a good candidate for post-op radiation, this is a good resource in terms of thinking about how you might design your fields. So you can go back to the paper I showed before that shows the lung contouring atlas in terms of how to define the nodal regions. And then this will actually tell you here what you might want to treat. And it's actually rather simple. You always end up treating the stump, the hilum, the subcarinal node, and then essentially a level above or below where your actual pathologic nodal disease is. This is a lot like head and neck cancer for post-op radiation as well. But it ends up meaning that your fields are a lot smaller, which in theory means your adverse event should be less as well. All right, so what about those patients for whom surgery is not an option or has not been determined to be the best option? And I think, arguably there really hasn't been a lot of advancements in the last decade or so. You know, most of our advancements came in the 80s and early 90s and early thousands, where we proved that chemo, some form of chemo was better than just RT alone, sequentially. Giving concurrent chemo is better than sequential chemo. And then we had a series of really massively negative studies showing that there's really no benefit to any additional consolidation chemo after that. And so that's where we kind of sat for the last 10 years or so. And what I want to talk about is maybe the two most important studies in the last 10 years. The first is that looking at the concept of dose escalation, the RTOG 0617 study, and then also a more recent study, the Pacific study, looking at immunotherapy. So why even consider dose escalation? So, for many years, the de facto dose was 60 gray at 2 gray per fraction. It's very simple. It's a dose that we're all comfortable with and we've used forever. But then in a series of studies, There was basically single-arm phase 1-2 trials. There was this notion that it was, quote, safe and feasible, and those are kind of soft endpoints. And admittedly, I have many trials that have those soft endpoints, but safe and feasible to escalate dose. And if you compare to those to historical standards, there was suggestion that there was a survival advantage compared to historical standards, going up to as high as 74 gray at 2 gray per fraction. And then the definitive trial was run. This was a 2x2 trial. It was a little bit convoluted. We're going to forget about the second part of it, which was a plus or minus cetuximab. That was negative. Cetuximab doesn't help. What we want to do is focus just on the dose part of it. And it was a randomization between 60 and 74 gray. The PI of this trial was Jeff Bradley. At the time when this trial came out, and he had spent the last decade of his life working on it, his office was right next to mine. And I will say that the results of this trial were kind of the results that shocked the world, because we were absolutely convinced. We already knew the answer. It was immoral to even run this trial. We already knew that more dose was better, except it's not. So these are the patients that were randomized to high dose versus standard dose radiation. 74 gray in blue, 60 gray in red. So 74 gray did worse. Worse overall survival. Now everybody, as soon as these results came out, everybody, except the PI, by the way, had figured out the answer about why this happened. So there was all sorts of theories about why. The most common one was the statistician flipped the curves. That's how convinced we were. Like, oh, this can't be right. They had to flip the curves. Let's go rehire a new statistician. They actually reran the stats because of that. You know, there's a lot of potential theories. One of them may be increased adverse events and toxicity. We'll talk more about that coming up. There also is the potential for the fact that people may have cheated a little bit on the high dose arm. Theories abound. Nothing has been proven. But you know, for what it's worth, even at 74 gray, the local control was not better. So we have worse survival, which may be related to adverse events in part, but we didn't even gain an improvement in local regional control. So there really was no tangible benefit to this. If you look at the predictors of survival in that study, you know, again, the most potent predictor was not getting, if you wanted to do better, it was getting treated on this All right, just got the thumbs up. So right after that power outage, I got a text from my wife telling me that the power was out. Again, where we were was just talking about this notion of, what are the things in a trial where you compare high-dose radiation to standard dose to predict survival. Again, I'll talk more about kind of the concerns around cardiac toxicity tomorrow, I think, or the next day. But one of the interesting things in this study, let me get my pointer. There we go. I'm teachable. Okay, was that increasing heart dose was associated with worse survival as well. We'll talk more about that later. But I think some important things that also came out of this study. So I think again, in 2020, if you're going to follow the results of I think the most potent definitive randomized trial that looks at the use of dose escalation, as of today, the standard dose is 60 gray. Now, I've had lots of people tell me, well, no, that says that just 60 gray is not good, and 60 gray is good, 74 gray is not good. That's too high. So I'll give 72 gray or 70 gray. and I think that kind of is missing the point. And it may be that there's some role for intermediate dose escalation, and certainly I wouldn't give up on the idea of it, but it needs to be in the context of a study. Now, what do we know from this trial, though? There's several important secondary analyses that have come out of this, and more to come. One of them is that higher accrual predicted better survival. Now, I want to be clear here. Higher accrual is not the same thing as academic institution. There's been lots of studies that have looked at academic versus non-academic institutions, and I think that's a very controversial type of a discussion to have, because the question is that driven by something uniquely suited by the experience of the radiation oncologists there? Is it just because they have more resources? And in this case, actually, the higher treatment volume they split centers into centers that accrued more than 3 patients versus less than 3 patients on the trial, and it was an independent predictor of better survival. Many of those centers, however, were actually community sites. So this actually means that the power of experience rests in your hands, and actually accruing to these trials may be part of the learning process as well. Something else that came out of this was looking at the use of IMRT. So in this trial, 3D versus IMRT was optional. It wasn't part of the randomization. You did this based off of your own choice. And there was a secondary analysis that looked at the use of IMRT and whether there was any benefit or not. And interestingly, in general, IMRT, not surprisingly, was used for patients that had larger tumors and more advanced disease, as sites at this time during this transitionary period from 3D to IMRT were trying to basically select the patients that might benefit. So despite the fact that it was actually used for worse tumors, there was actually less grade 3 pneumonitis. So the use of IMRT was associated with less grade 3 pneumonitis in this trial, despite the fact that it was used for worse tumors. That would be a good question to remember too. So IMRT does improve toxicity in this trial. And again, reiterating that lung V20s remained our best predictor in this study. IMRT also happened to result in lower heart doses. And again, despite accounting for use of IMRT, heart dose still was an important predictor. We'll talk more about that later. So what about quality of life? So I think quality of life is now integrated into nearly 100% of the prospective trials that we have now to date. It's a very important patient-centric way to look at things. And so this was another secondary analysis with Ben Mofsis and others that looked at the quality of life that was captured on this study and showed that at baseline, quality of life was similar, but in patients who then were randomized to the higher dose arm, they had a significant decline in generalized quality of life. Now, it's not granular enough for us to really drill into the significant drivers as to why that happened, but I think it's another nail in the coffin of understanding that there's probably some patient or physician-reported things that failed to get captured. There's lots of data that suggests that physician-reported outcomes are really subpar compared to what patients can tell us. So there's a lot that's probably hiding in that high-dose arm that we really are having a hard time teasing out. But again, IMRT actually improved the quality of life compared to 3D. So as we think about that notion of toxicity, then it would be natural to start to think, well, if IMRT could be used as a tool which seems to improve quality of life and reduce pneumonitis, what about using something like protons? So, you can make really great pictures, and we've all done this, those of us who have proton centers, where you compare the kind of the difference in dose between X-rays, IMRT, or 3D IMRT and protons. And what you will universally see in all of these, whether you have passive scattering or IMPT, is that protons are really, really good at preventing you from having lower dose scatter, low and intermediate dose scatter. And so the question then becomes, does that low and intermediate dose scatter reduction with protons translate into improved outcomes for patients? Now, almost 8 years ago, ASTRO put together a evidence-based review. At the time, there really was no evidence to talk about, so it was more of a consensus document. And again, the kind of potential benefits of protons would be that there would be sparing of uninvolved lung from unintentional radiation, but there are some potential pitfalls. Protons are uniquely challenging to use in moving tumors. There's a lot more sensitivity to changes of the density of tissue in line of a proton beam path. There's many physics papers that have been written about how to deal with that. I think it's manageable. It's obviously there's more cost, and at the time of this paper, there really was no evidence to look at whether or not there was a benefit or not. There is now the first randomized trial. Now, admittedly, it's a bit of a doozy. It's a complicated one. I think it was really rationally designed. But it's also a great example of how hard it is to run technology trials, particularly in the modern era. This was a Bayesian adaptive randomized trial, so there's a lot of kind of complexities of how you would get into this trial as a patient. A lot of it was also influenced by insurance. So if insurance wouldn't pay for it, then it kind of shuttled you into a different arm. So there was an inherent bias at the outset. Insurance really messed with this trial and then the subsequent randomized esophageal cancer trial as well. But the overwhelming hypothesis overall was that, again, that reduction in lung dose and reduction in dose to organs at risk would result in improvements in outcomes. And so, in fact, they did show that protons were associated with lower intermediate and low dose, V5, V10 to the lung, but no difference in V20. In fact, actually, the V20 was a little bit higher than IMRT. And the kind of principal hypothesis was that there would be improvements in pneumonitis. Grade 3 pneumonitis was not better with protons. There was no difference. In fact, numerically, it was actually a little bit higher. Again, no difference in local failures. So overwhelmingly, this is not a big win. This is definitely a stalemate, possibly a loss for early use of protons for lung. But having said that, because of the issues, this was during a transitionary time, moving from different types of proton radiotherapy. Whenever you compare two different, an established IMRT regimen versus an evolving learning curve treatment, that's always going to be challenging. But I think importantly, a good question one might ask is if there was an improvement in pneumonitis with use of protons, which there was not. Which brings us to the kind of title of my talk, which is in the immunotherapy era. So the Pacific trial, I think, is maybe one of the most exciting trials that I've seen in a long time for lung cancer. And this was a randomized phase 3 trial for patients who had locally advanced non-small cell lung cancer, exclusively accrued outside the US. So one thing to keep in mind is that we actually really have, we have really no RT quality assurance to look at to look at some of the subsequent outcomes. And these are patients who got chemoradiotherapy, and then for the patients who didn't progress, they were then randomized to consolidation durvalumab, which is a checkpoint inhibitor drug, given every 2 weeks for up to a year. And it was a 2-to-1 randomization versus placebo. And the co-primary endpoint was progression-free survival and overall survival. So again, what is durvalumab? It's a selective high-affinity human IgG monoclonal antibody. It's an anti-PD-L1 inhibitor, so it's a next-generation checkpoint inhibitor. This has been used in many different trials, and it's one of a cluster of immunotherapy drugs that we're starting to see used more in practice. The reason this trial, I think, was so exciting, though, is because, as I mentioned before, there had never been any trial that to date had shown an advantage to consolidation therapy that was definitive. There were some trials that looked at the adjuvant taxanes, and there was a suggestion of a possible benefit, but that was subsequently shown to be negative in a randomized trial. And here we are taking patients who've received toxic, definitive chemoradiotherapy, patients who, as you and I know, at the end of treatment are really sick and you know, they're struggling to recover from their esophagitis and maybe their cytopenias. Not usually somebody you would think about that you'd want to now give a year of some additional agent to. But in fact, what they showed in this trial was that there was initially, in the initial publication, an improvement in PFS, a really large improvement in PFS. So 12-month PFS, 56% versus 35%. And that subsequently did translate into a survival advantage, which we'll talk about in a minute. Importantly, though, there was a small increase in the risk of adverse events. And the major adverse event that we worry about, of course, is pneumonitis. And these drugs on their own can cause pneumonitis. So the question is it additive? And the answer is no. So there is an increased risk. So any grade pneumonitis was 34% versus 25%, so about a 9-10% increase in the rate of any grade pneumonitis. But importantly, though, that was low grade, grade 1, 2. There was only a less than 1% increase in the risk of high-grade pneumonitis. You know, if you kind of look at this in the individual components, in the initial paper, they gave this really strange composite endpoint, which is hard to interpret. This was the time to death or distant METs. So I'll skip past that. This is the newest data. This has been reported in the last year or so, and this is the actual overall survival data. So again, randomized consolidation immunotherapy, relatively low risk of any serious adverse events, although we'll talk more about how to manage some of these unique ones in a moment. Median survival not reached versus 29 months. Now, one thing to point out here is that in the placebo arm, 29 months compared to historical controls is a pretty solid median survival for stage 3 non-small cell lung cancer treated with definitive chemoradiotherapy. And there's a number of reasons that probably is the case. Number one is that this is part of the creep of increased utilization of PET and improved staging. Number two is improved just general treatment of these patients. The last is that there's a hidden little nugget here, which again is that the patients were only randomized if they didn't progress after chemoradiotherapy. So we've all seen those patients who get chemoradiotherapy and like literally within their first restaging scan, they already have distant disease. Those patients wouldn't have been on this trial. So again, the control arm is a little bit higher than average, but you have to remember that even despite that, there was an improvement in OS with the use of this drug. Now, did all patients benefit? You know, as is classic for these trials, they'll go back and they'll look at these, you know, forest plots and try and figure out who benefits. And I think maybe one of the ones that's the most impressive here, and maybe not unexpected, is the EGFR status. So again, EGFR, these patients, about, you know, depending on the study you read, 5 to 7% of patients may have these mutations. Because it is a driver mutation, it tends to be something that doesn't also then happen in the context of having high expression of something like PD-L1, which is a marker we use for sensitivity for these immune therapy drugs. So not all patients seem to clearly benefit from this. There's also some question of whether or not PD-L1 status was a good predictor. But again, overall survival was improved, and that would seem like also a good question we might want to ask there at the end. Again, I just want to speak to this toxicity issue, so I'm just going to drive actually to this next slide. So the pneumonitis is important because, you know, these drugs, as I mentioned, in the metastatic setting, even without radiotherapy, can cause pneumonitis. And in fact, actually, one of my favorite things to see now is we'll have these patients who haven't ever received radiotherapy, and then they come to my appointment for like a second opinion, possibly treatment of oligoprogression, and they have a CT report that clearly says that they have radiation pneumonitis. We've all seen this, right? It's just the whipping boy of oncology here. And I'm like, well, that patient didn't even get radiation, so welcome to our world. But the risk is real, and fortunately it's low. But having said that, I think you need to get a little situational awareness with these agents. This is not what we're used to seeing. You know, when I see someone treated with platinum-based chemotherapy, I know what to look for. I know what to look for in terms of their cytopenias. I know when to expect their esophagitis. I know that the fact that they're going to get neuropathy, and you know, other forms of neurotoxicity, ototoxicity, nephropathy, and these are all the things that I feel comfortable with. But then you layer in immunotherapy, and anything goes. Any organ in the body is something that could get an immune-related adverse event. And some of these can be really exceptional. So you can shut down someone's pituitary gland. You can actually have we just had a case last week at our tumor board where they were telling us that they're seeing increased rates of direct damage to the exocrine component of the pancreatic system. And colitis is an important one as well. And so anything goes. So I think paying attention when a patient comes into your clinic and you're seeing them at that initial follow-up or subsequent follow-up and they start complaining of, severe fatigue. It could be hypothyroidism or pituitary dysfunction. They're complaining about things that seem off. Talk to your friendly medical oncologist. But importantly, there's a lot of these that overlap. Some of these toxicities overlap. So I mentioned pneumonitis multiple times now. But the same thing goes for GI, xerostomia, hypothyroidism, hepatitis. These things can happen independently just with the immunotherapy drug alone. And so I think if anything, this means that we have to open up the doors of communication with our medical oncology colleagues even more. The timing also is important. These are not late. These are not late effects. These are things that tend to occur, unfortunately, within the window with when we often see those kind of early adverse events from radiotherapy as well. And so, you see a lot of these things like the dermatitis and skin toxicities and hepatic toxicities and pulmonary toxicities that can happen a lot of times within that window that we may see radiation toxicities. So for example, how might you consider managing somebody who comes in with pneumonitis? I think importantly, the other thing to remember is that these patients, if they get pneumonitis, they can more rapidly progress and get sicker than what we're used to seeing with radiation pneumonitis alone. And so because of that, there's some best practice guidelines that have come out. And so this is from ESMO, and their recommendation, and this is primarily in patients who've been treated with immunotherapy alone and get immunotherapy-related pneumonitis, is it in low grade, so that is radiographic only, or symptoms that are somewhat manageable, interrupt the immunotherapy, so importantly, stop the drug, rule out infection, give some steroids. And then we'll talk in a minute about whether or not you might consider re-challenging those patients. In patients who have higher grade toxicity, that is life-threatening, they get put into the hospital, or they get life-threatening adverse events, their general recommendation is to discontinue immunotherapy permanently. Sometimes steroids isn't even enough for these patients. Sometimes the immune-related adverse event is so severe, they're putting these patients on infliximab or cyclophosphamide, really heavy-duty immune suppressant drugs to control some of this. Now, we've looked at this because the survival advantage is so profound. You'd hate to get somebody who has an adverse event like pneumonitis and then say, well, you had 1 or 2 cycles, sorry, you don't get to complete the full course of therapy, which was associated with improved survival. So in our study, we combined a couple different institutions and looked at real-world use of this drug, which is really modest at this point. I mean, the approval's only about less than 2 years old for this drug, so there's not a lot of long-term experience yet. And so what we found in our combined institution is that about 25% of patients developed pneumonitis, grade 2 or higher pneumonitis. And of those patients who developed grade 2 or higher pneumonitis, we were able to successfully re-challenge 70% of those patients. So re-challenge is possible. You may re-challenge these patients. And I do think it's worth talking with your medical oncologist about because, again, this is maybe one of the largest improvements in survival we've seen in our field in a long time. If I was to ask a question, for example, whether you could re-challenge patients, this would be a good one to know. So last but not least, where are we going in the future here? So, clearly there's a doubling down on immunotherapy. Immunotherapy is here to stay, or at least until the next drug comes out, I guess. But for now, the things we're looking at, immunotherapy to date, as per the Pacific trial, was used in the consolidation setting. So what happens if we move it into the concurrent setting? Is that safe? Is that practical? Is that improve outcomes? And that's been looked at now in the Pacific 2 trial, which is yet to be reported, and several other trials from other manufacturers. There's some novel immunotherapy agents, some that have dual modalities of action, anti-PD-L1 and anti-TGF-beta, where it may actually protect against radiation fibrosis and pneumonitis. People are even combining drugs. Actually, MD Anderson's done some great work in this case, early phase trials combining both the anti-PD-L1s and then the earlier generations, the anti-CTLA-4s that we use a lot for melanoma. And then I think hypofractionation is becoming very popular as well for many reasons. One, because we're realizing as a field that we can get more comfortable with this notion. I think of this as the intermediary. This is the porridge is too hot, too cold, just right. So clearly you can't use just SBRT on its own, although one might consider doing SBRT boost, as Dr. McGarry has done in his data. But there's increasing evidence that you can compress that schedule 60 gray and 30 fractions down to as low as maybe 15 fractions. Here's some results from a trial that we recently reported, not in manuscript form at Astro so far, where these large tumors, we had really successful tumor control rates, up to more than 90% 2-year control by hypofractionating. Again, could this be given with immunotherapy? And NRG LU004 is a cooperative group trial looking at that today. So with that being said, I'll conclude here. I think importantly, if we could just keep the lights on for just 2 more seconds. Appropriate workup is key to determine the optimal course of therapy. Really impressive results with induction immunotherapy as an alternative to what we're doing with definitive concurrent chemoradiotherapy and adjuvant immunotherapy. If you're considering port, there was historic trials that says don't do it, and there's many of us who've just kind of originally eliminated it from our paradigm, but I think evolving data suggests you might consider doing it. Pure, and it's funny, this is totally a typo, purse dose escalation, but it seems appropriate. Pure, yeah, fill one's purse. Pure dose escalation does not improve outcomes in locally advanced lung cancer. And then again, immunotherapy is very exciting, but caution as we move forward into this era. And I think just being open about how those patients may experience different adverse events will make us all better in the long run. And that's all I have. Thank you.
Before we start the SAM, does anybody have any questions?
Right in the back, and then Sue.
Just in the setting where someone's getting immunotherapy for, say, metastatic disease, and you're asked to radiate the lung for local control palliation, do you tell them to hold immunotherapy for?
Yeah, so I'll repeat the question, and we'll talk a little bit more about this because we have a whole separate oligomet section, and Joe had talked a little bit about this too. So the question was somebody who has metastatic disease who's on immunotherapy, so very different than this, where now you want to consider giving consolidation RT. Do you hold the immunotherapy? And the answer is I have no idea, because this is not cytotoxic. So with cytotoxic, you could figure out what the half-life is, and you could say, well, it's out of their system, go ahead and give the drug, give the radiation, and then start the chemo again. But the problem with the immunotherapy is that even if you figure out the half-lives, it's kind of irrelevant because it's the immune response it's created. There are some people who get 1 or 2 doses of a drug, and they have profound immune activation. And so holding that person's drug is going to do nothing to protect them from any, adverse events. So, what I've been doing is saying, well, don't give it the same day I give SBRT, I guess. I don't know, that makes sense. But beyond that, I don't know. And I think there is now evolving data in lung in particular that suggests that it's probably safe to give together. We'll talk the next day about this Pembro RT trial where they gave pembrolizumab and radiation together. They did okay. But I don't know.
So one question, they give durvalumab every 2 weeks for the rest of the patient's life effectively. Do the patients ever develop an immune response against the durvalumab antibody, i.e. an anti-endotypic response?
Yeah, so the question is, let me kind of answer that backwards. There is a very small number of patients who actually develop a direct sensitivity against the drug. Just as a clarifying statement, though, they don't actually get the drug for their whole life. So they get it for, in the Pacific trial, it was given for 1 year.
Our people give it forever.
Okay.
There's also about 10 or 15% of patients who can undergo a rapid proliferation of their tumor related to immunotherapy. It's 10 or 15%.
Yeah.
And likewise, they like to quote pseudo-progression, which is a non-issue effectively.
Right.
What's your take on that?
Yeah, so I think, so again, speaking to this notion that there's now been multiple reports of, in the initial 1 to 2 cycles of immunotherapy, this is mostly in the metastatic setting. It doesn't seem to happen as a consolidation effect. But you can have somebody with Mets, they get immunotherapy, and suddenly their tumor blows up, and then if you just keep them on the drug, it collapses again. And in those patients where they've resected the tumor, there's a lot of T-cell infiltration in those tumors. That's what they tell us. I would say, though, we've been dealing with pseudoprogression our whole careers. So again, just like pneumonitis is like a new thing for them, like welcome to our world, where the imaging is insufficient and we don't know the right answer. You have to make judgment calls clinically. See, were you good? You had your hand, but then you put it down. Yeah, that's fair.
Our medical oncologists are now testing all our stage 3 patients for mutations. They use one of the free services that you can get if you're in that world. And the reason they do that is because they do not want to give durvalumab to patients who have driver mutations who are stage 3. So I'm just wondering how your institution's handling that, because the evidence is pretty clear in the metastatic setting that patients who are EGFR ALK, probably BRAF, don't respond to durva, and
Yeah.
it's actually harmful
Yeah,
to give that to them because you reduce their response to EGFR inhibition later.
Right. So I would say that at our
And
institution,
testing for stage 3 is
Yeah.
controversial. You're not supposed to do that, but they get away with it.
Well, I think you just answered your own question. So again, do we test stage 3 patients for mutations? At our institution, we do not have the ability to do reflexive testing. So for metastatic patients, if they're known to be metastatic and they get a biopsy, the pathology group will reflexively test the normal panel of EGFR, ALK, ROS, KRAS, et cetera, BRAF. But I'm pleased to hear that you guys have access to that. I would say for many of us, it's challenging to get that paid for. All right, let's go ahead and do our SAMs, shall we? Okay, question number 1. In that Nadim study, that study I mentioned a couple of times where patients got induction nivolumab and drugs, and they had really, really, really impressive downstaging. What percentage of patients had downstaging in that trial? 5%, 25, 50, or 90? 10 seconds. Very impressive downstaging. Okay, 94%. Not bad. All right. So again, just mentioning, there was a 90% downstaging in that study. Major pathologic response was 86%. So something for us to keep in mind as we move forward with our trials. So again, RTOJ0617, this has been picked apart many, many times. So this was 60 versus 74 gray. Which of the following is true? Which of these is a true statement? So did 74 gray have improved overall survival? Superior local control. Was IMRT associated with less pneumonitis? And was quality of life improved in the high dose arm? So we'll take those answers right now. 10 seconds. I wrote the questions down and make sure I got the SAMs right in here. I got 100%. Yeah, there you go. You're really messing with our OCD as radiation oncologists, right? We want everything perfect. So, okay, I think we know the answer here. Okay, so in the only randomized trial, the Bayesian adaptive MD Anderson IMRT versus protons for lung cancer, which of the following is true? Did protons improve overall survival compared to IMRT? Did they improve local control? Was the rate of radiation pneumonitis not different between them? So was pneumonitis the same between those two arms? And did protons improve the V20 as opposed to the low dose, the V5 and the V10? So which of these is true? Very good. That's right. No difference in pneumonitis despite the improvement in dosimetry. Okay, second to last question, talking about the Pacific trial. So this is the trial comparing a year of consolidation to placebo. Did durvalumab improve survival compared to placebo? Was durvalumab associated with a really, really high rate of adverse events and pneumonitis? Did all patients benefit from durvalumab? And then the last one is the antithesis of the first one. Consolidation durva did not improve PFS compared to placebo. So which of these is true? Okay. Excellent. All right. Last but not least, what if you do treat a patient with the Pacific regimen? So you're going to give them Pacific type durvalumab after their chemoradiation. Which of the following is true regarding adverse events? In the event of a grade 1, 2 pneumonitis, meaning any pneumonitis, you should go ahead and just continue the drugs. No steroids necessary, don't worry about it. Immune-related adverse events are very late. They tend to happen after a year. Patients who develop pneumonitis may actually be rechallenged with durvalumab, or immune-related adverse events are only lung. There's no other immune-related adverse events, they're only lung-related. 10 seconds. I hope this is not the clock to when the lights go out again. No? Okay. Yeah, all right. Excellent. Outstanding. Okay, thank you very much.
Thank you, Dr. Robinson. So next we have Dr. Lynn Taylor. She's a professor at the University of Washington. She had her MD from Washington University and her residency at Hopkins, and then actually did her fellowship at Memorial Sloan Kettering. And her specialty is neuro-oncology. So we'll welcome her here to talk about neuro-oncology.
Good morning, everybody. Thanks for staying with us. I want to thank Drs. Courier and Yashar for inviting me. As probably the only non-radiation oncologist in this room, so my first full disclosure is that I'm not a radiation oncologist. I'm a neuro-oncologist, and I'm going to be talking about tumor treating fields, primarily for use in newly diagnosed and recurrent glioblastoma. I'll touch on the use of tumor treating fields very quickly for pancreatic cancer, mesothelioma, ovarian cancer, and lung cancer, But that's only to show you that this modality is being looked at in a variety of diseases outside of the brain. So my disclosures are, first of all, my superior talk included some pictures of Brainiac, which Dr. Heath Foxley told me about yesterday. So I added 5 or 6 slides of Brainiac. And I had been unaware of who Brainiac was in the past. So you're going to have to Google Brainiac on Google Images later, but this was apparently Superman's arch nemesis. And it was a green gentleman with red knobs on his head, which were said to be neuronal synapses. Dr. Foxley pointed out that between 1970 and I think 1995, Brainiac had multiple looks, but all of them looked remarkably like a patient wearing an Optune tumor treating field device. So you'll just have to imagine that, but my talk would have been superior with those pictures of Brainiac in there. The second disclosure that I will make is that I was approached to be a principal investigator on an Optune trial when I was a neuro-oncologist in Seattle at Virginia Mason, and I rejected the opportunity because I thought the science didn't make much sense to me, and I just didn't think it was a modality that would really be effective, so I turned it down in 2010. Then in 2011, I had the opportunity to move to Tufts Medical Center in Boston, where I stepped into the shoes of Dr. Jay Zhu, who had gone to Texas. As these happened, I became principal investigator of the EF14 clinical trial at Tufts Medical Center, and by virtue of putting 19 patients on the trial, I became the 7th author of the 2015 article that suggested that adding tumor treating fields for glioblastoma was now standard of care. So what's unusual about that is the company cannot really understand why, when my name is on the paper, I'm the least likely of our group of 4 neuro-oncologists to actually give this to patients, and we can certainly talk about that at the end if you have any interest in why that might be, despite what I'm going to tell you. So, those of you who were at ASCO a couple of years ago were probably in this audience of thousands of people, standing room only, where Dr. Stoop talked about the addition of tumor treating fields to surgery and radiation therapy. The one slide that I think was really most effective was a single slide, a cartoon of a baby chick coming out of an egg, and the baby chick coming out of the egg stood there and said, "Whoa, paradigm shift." And that was how Dr. Stoop introduced the concept of tumor treating fields to this large audience at ASCO. So there, of course, is the device, which I'm sure you're all familiar with. We're going to talk about the scientific principles behind it, some clinical data primarily as it relates to glioblastoma. I'm going to zoom past the articles on other solid tumors, but just to let you know that they exist. We'll look at the clinical use, the toxicity profile, and future directions. So the proposed mechanism, oh, this is so great. Wow, okay, sorry. The proposed mechanisms, as you know, there are these classes of septins in normal mitotic activity, which create this cleavage plane here to allow cells moving from anaphase to go through telophase and produce 2 cells. The idea with tumor treating fields is that these septins are put into these rotational forces, which keep them from behaving in a normal fashion. This cleavage plane is not able to be produced, and the cells undergo not really apoptosis, but this strange cellular blebbing, and they die because these fields are just not properly aligned. The proposed mechanism of action as well is that in a cell that is not dividing, you'll notice that these the fields are fairly uniform throughout, and these direction of forces do not produce a lot of change within the cell. But in a dividing cell, all the activity goes towards the central part of the division of the cell, and these net forces act again to disrupt the cell membrane. And this cartoon hopefully shows you that these forces are quite significant inside the dividing cells, whereas in these other cells, they're fairly, a single quiescent cell, they're quite uniform. I think this is just a beautiful slide, so I'm going to put this up here for you to contemplate for a moment. This is work based on Curson that he published in 2004, basically showing that the size of the tumor cell is inversely related to the size of the tumor treating field, frequencies that create cell disruption. You'll notice that the optimum frequency for glioblastomas is 200 kilohertz, which might be a good question. And you'll notice that for normal intestinal cells, it's much lower. The range of activity, though, is across most tumor lines fairly significantly located between 150 and 200 kilohertz, 200 kilohertz for glioblastoma, and obviously the highest dose for the smallest cell, which is small cell lung cancer. Again, another beautiful slide from that Curson article in 2004, showing you that, of course, the control in black and the treated cells in white normally go through prophase, metaphase, anaphase, telophase, and that in the treated cells, there's a lower proportion of those cells undergoing that change. You'll notice that in the treated cells, there are a variety of abnormal mitotic examples, which are all quite beautiful and which they show you here. A is, they call it a polyploid prophase. B is a rosette. You can see why they call that a rosette. C is separated metaphase. D is a multi-spindled metaphase. E is a single-spindled metaphase. And F, an asymmetric metaphase, showing you, I don't think this pointer works. It seems to want to advance instead of pointing. Thank you. This slide is meant to show you that this effect of tumor treating fields is not seen in healthy tissues. You'll notice here 7, 14, and 28-day control, 7, 14, and 28-day tumor treating fields in lung, kidney, spleen, liver, brain, no effect, either treated or untreated, and white cell counts, basophil, eosinophils, lymphocytes, again, no effect, as published by Joe in Cell Death Discovery in 2018. Again, from this Curson article, trying to identify the optimal treatment frequency, which varies across cell lines. You'll see here they looked at a great number of cell lines, and then they also looked at the same types of cell lines, but in actual tumors, showing that the optimal frequency of treatment for mouse melanoma, Chinese hamsters, human breast, and then human glioma at 200 kilohertz. So the clinical data is that the FDA has now approved tumor treating fields for monotherapy in recurrent glioblastoma, for newly diagnosed glioblastoma when used with temozolomide, and for recurrent mesothelioma. There are also phase 3 registration trials ongoing for non-small cell lung cancer, pancreatic, ovarian, and brain metastases. Oh, so tumor treating fields as monotherapy. There you go. There's Brainiac. So it did work. It just wasn't called that. So this is Brainiac, Superman's, I guess, arch nemesis with his Brainiac device on his head. This is from Stoops' European Journal of Cancer in 2012, showing that the difference between tumor-treated fields and best personal choice chemotherapy separates here at the end, and Novo TTF versus best personal choice chemotherapy. There was not a fairly significant survival difference, but the argument they're going to be making is that Novo TTF, compared to best choice chemotherapy, has remarkably fewer side effects and therefore may be non-inferior. This very small trial of 30-ish patients also looked at whether tumor treating fields could be used in bevacizumab refractory glioblastoma patients and showed that the use of Novo TTF was superior to best choice chemotherapy. And that difference seemed to be most for patients in the 60 to 79 year age group, though the number of patients below the age of 60 with bevacizumab refractory glioblastoma was very small. These are two patients just showing the results of tumor treating fields. The first is a man in his 40s who had a grade 2 astrocytoma, which changed late in his course into a left frontal enhancing lesion that you see here as a glioblastoma. This first recurrence after radiation therapy and temozolomide was treated with TTFields alone, and here you see the tumor at 6 months and 12 months having lost all of the enhancement and mass effect. These obviously are single patients. This is another patient who had a third recurrence after radiation therapy and temozolomide. He was also treated with bevacizumab, irinotecan, and erlotinib, and had this large mass lesion in the left temporal lobe, which also responded at 6 months and 12 months to tumor treating fields. Tumor treating fields has also been used as combination therapy. Here you can see Brainiac in a later, I think about 10 years after his first incarnation. This is probably the most important slide in the presentation, showing the timeline for clinical breakthroughs for glioblastoma. As you all know, initially reported in 1976 by Salazar, the overall survival for our glioblastoma patients was no longer than 2 months. In 2020 parlance, that group, of course, is probably the IDH wild-type glioblastoma cohort over the age of 70. The second article that came out with surgery and radiation therapy in 1976 showed that the overall survival was dramatically impacted, as you all know, by the addition of surgery, which added at least 10 months to overall survival. Then the Snoop trial in 2005, showing the addition of radiation therapy and temozolomide increased overall survival by another 4 months. And then finally, Snoop again in JAMA in 2015. Showing this very significant increase in overall survival from 14 months to 20 months, so an additional 6 months. I looked hard for this particular paper and could not find it to refer to, but I heard a very good point-counterpoint about tumor treating fields at ASCO, or maybe the Society for Neuro-Oncology, a few years ago. And the person who gave the talk looked at a paradigm for congestive heart failure where patients were asked to follow a complex treatment regimen or they were asked to follow a simple treatment regimen, and they simply looked at the question, what kind of survival benefit do you get from being able to follow a complex treatment regimen? And the answer was about 5.5 or 6 months. So one of the arguments, despite these numbers that I'm showing you and the FDA approval for tumor treatment fields, is that I think there is a huge selection bias, and the regimen, of course, is quite complex. So we may be choosing those people who are able to comply with a complex treatment regimen and then accepting this overall increase in survival because of tumor treatment fields rather than something that we or the patients have chosen irrespective of the device. So many would argue that it is now the standard of care for newly diagnosed glioblastoma because temozolomide and tumor treating fields give a median overall survival of 24.5 months, whereas temozolomide alone, a median overall survival of 20 months. So again, that 4 to 5-month increase in overall survival. And importantly, 5-year overall survival, temozolomide and tumor treating fields, 13% temozolomide alone, 5%. So pretty compelling numbers if you just look at the face of it, and maybe you should. There is a dose response curve, and that needle is changing a little bit over time. The optimum time of treatment in terms of dose response would be greater than 75% compliance. And so it comes to pass that we tell our patients that there's no point using tumor treating fields unless you're compliant over 75% of the time. In the clinical trials that we were involved with, that compliance was defined as greater than 18 hours per day, but now the compliance is defined as greater than 75% of the month. So when you do the math, it basically may give you, if you were compliant 24 hours a day, you might get 7 days to spend in Hawaii without wearing your tumor treating fields if you were compliant only 75% of the time, but only get maybe 3 days when you could be without the device if you were compliant 90% of the time. So the original articles that came out looked at 75% compliance, but this article by Toms in the Journal of Neuro-Oncology, published just last year, looked at compliance and actually showed that if you increased your compliance from 75% to 90%, the improvement in median overall survival was 16 months for temozolomide alone and 24.9 months for tumor treating fields and temozolomide. So FDA approval was April 8th, 2011 for recurrent glioblastoma. The contraindications are active implanted medical devices such as pacemakers or shunts, any kind of skull defect that's present, and then a known sensitivity to the gels. For newly diagnosed glioblastoma, that FDA approval came October 5th, 2015, and you'll notice that the indications for both recurrent glioblastoma and newly diagnosed glioblastoma are the same: 22 years of age or older, a tumor in a supratentorial, not an infratentorial location, and the newly diagnosed was to be used with temozolomide, whereas the recurrent was to be used as monotherapy. And then the exclusion, spinal cord stimulators, vagal nerve stimulators, defibrillators were the same in both cohorts. Then in 2019, the FDA approved the use of tumor treating fields for mesothelioma. This was a small study of locally advanced or metastatic malignant pleural mesothelioma patients with good ECOG performance status. They were required to use the tumor treating fields, again, that 18 hours a day or the 75% compliance. They were treated with pemetrexed and platinum. You'll notice that even though they were said to be, they were meant to be compliant over 18 hours a day, many of them could only manage it 16 hours a day because of heat and discomfort from the leads, and they had to have at least one measurable lesion. The progression-free survival in that study was 7.6 months against a 5.7-month historical control. There was another study looking at non-small cell lung cancer, again, very late-stage patients, stage 4 non-small cell lung cancer, or inoperable stage 3B with pleural effusions, and they looked at out-of-field and in-field progression and tried to make the argument here that there was a small improvement in the median overall survival out-of-field versus in the field of the tumor treating fields. And this is looking at a single patient with 5 separate pulmonary lesions here and a mediastinal mass, trying to show that with the application of tumor treating fields, there was a change in the size of the tumors, all of the tumors, over time, and that this single patient had an in-field progressive disease noted in the liver 10 weeks after developing multiple intracerebral metastases out of field. This has also been looked at in recurrent ovarian cancer, stage 3, serous patients treated with paclitaxel using tumor-treated fields tuned in the same way that we tune them for glioblastoma patients, and 25% had partial response. 1-year survival rate was 61%, with historical first relapse at 12 months, and the median progression-free survival in this study was 8.9 months. And lastly, a trial in newly diagnosed pancreatic patients showing a survival benefit, again, in a very small cohort of patients. Additionally, there are key clinical trials being looked at in hepatocellular carcinoma in the HEPANOVA trial and in brain metastasis in the METIS trial for non-small cell lung cancer. Turn it over. Yeah, I think so. Thank you. Thank you. So this is the clinical trials and publication timeline of Novo TTF, showing how far we've come in the last 19 years. So the pivotal EF07 glioblastoma trial began in 2004, the EF11 trial in 2006 of recurrent glioblastoma, and the EF14 trial of newly diagnosed glioblastoma in 2009, which led to the FDA approval for recurrent glioblastoma in 2011, as we have discussed. There have been a lot of articles published since that time, leading up now to 2019, suggesting or giving FDA approval for unresectable mesothelioma. These are what the arrays look like in place for a patient with ovarian cancer, pancreatic cancer, obviously glioblastoma, and mesothelioma. The treatment planning is something that one can learn to do yourself, and there's even a billing code for it, but most of the neuro-oncologists that I know, and maybe many of the radiation oncologists who use this as well, don't usually do our own treatment planning. We leave that up to the company. Patient training, back in the old days, we actually had to bring the patient into clinic. We were responsible for shaving the head and placing the arrays, and then we even had to turn it on in the clinic. This is way back when. Obviously now, all that patient training, as you know, takes place at home, and the company does a really good job of patient and family support. It is known that the dose correlates with survival for glioblastoma, so the location and placing of the arrays is really quite important, and that's why I leave that particular function to the company. The toxicity profile obviously is one reason why we do choose to stay away from tumor treating fields in some of our patients. This can be quite painful. It can be very hot. A lot of my male patients who wear the device in the summer and sweat actually have the arrays kind of slide down, so it can be very cumbersome. The pictures of people wearing the device, of course, always show them smiling. And I would have to say it's interesting how my patients kind of divide themselves into two cohorts. There are some who I would say really do have a clearly improved quality of life from using the device. Most of those have a caregiver at home doing the hands-on application, the shaving of the head, the placing of the arrays, and I actually think that one-on-one caregiver support goes a long way to making people feel an improved quality of life. The skin toxicity, of course, does not. This is a fairly typical appearance of many of our patients wearing the device. This kind of skin toxicity can be dealt with by moving the arrays to a different place and is not that difficult or painful for many. Obviously, very pale people particularly have this skin toxicity, particularly in the summertime, particularly if they're going out in the sun. But this shows that this right lower extremity application, the same kind of skin toxicity occurs when it's outside of the scalp. So this toxicity of tumor treating fields was seen across all studies, as you can see here. Generally, this is fairly mild skin irritation, 16% in the F11 trial, 43% in the F14 trial. Grade 3 and 4 toxicity was small, but most people had this sensation of heat underneath the arrays and also an electric sensation, as they're describing it here. I would say I do worry about post-traumatic stress disorder, particularly in some of our patients with very coarse or rapidly growing hair. That hair can grow very quickly, and as soon as the arrays lift up from the scalp, the machine starts pinging, and very often patients get a really sharp electric sensation, which is painful. It's more than just a sensation, and it can lead to quite a lot of disability and upset, and so it's interesting to me that they place it here under unspecified toxicity. So this, I think, this 2% grade 3 to 4 toxicity is the one that we worry about the most. And as you could imagine, outside of clinical trials, the skin toxicity is much more significant, including this example here of an obviously pustular lesion. The treatment of the dermatitis, the erosions, the infections, and the ulcerations is all quite similar. With grade 0, you're just to remind the patient about shifting the arrays back and forth. Grade 1 is generally treated with topical corticosteroids, with the caveat that if you think it's an infection, obviously culturing and using a topical antibiotic would be appropriate. For grade 2, taking a break from treatment and using the high-potency topical corticosteroids is recommended. And then for most of us, anytime it gets to be a grade 3, I would not really continue that treatment without getting dermatology involved. Quality of life is an issue that we've touched upon, and it really doesn't seem to be particularly different between tumor treating fields and temozolomide versus temozolomide alone. Understanding again, though, that you have a very specified patient population who are very usually eager to continue the device and willing to put up with a lot for the improvement in overall survival. I still keep in touch with one of the patients from the EF11 clinical trial who was a pilot in Quebec. He actually went and spoke about the device to the FDA. He's been wearing it over 5 years now, and he goes bungee jumping wearing this device. He actually makes it look like a fashion statement. I don't know how. But the people who do well with this device really do well and really don't find it burdensome. Obviously, those who do drop out fairly early. You'll notice that if you look at a different quality of life index, which is itchiness of skin, there's no question that the TTFields patients get that symptom much more significantly than those patients using temozolomide alone. And if you look at quality of life overall, this does tend to favor tumor treating fields plus temozolomide, with the exception of role functioning and social functioning, and then itchy skin, with the two being the most important, of course, are roles functioning and social functioning. And again, patients vary. Lots of my patients will use it as an opportunity to strike up conversations on the street. Most people do get stared at. They do get asked a lot of questions. Some of our patients embrace that. Others find it to be a detriment. So you've seen this slide before. I just switched it so that the recurrent glioblastoma indications are on the left because they were earlier in April of 2011, and the approval for newly diagnosed in 2015. The caveat that you can't use this device with programmable shunts, there have been some patients and families and physicians who've pushed back against that a little bit. This was a retrospective safety study on only 5 patients with pacemakers and defibrillators, published in Neuro-Oncology in 2017. Obviously, you can see that this is a single patient with a programmable shunt at various times and days. They turned the Optune on and off, and then looked at the settings which were not at all affected by the device. So it is possible to use this in a patient with an implanted device if you as the physician feel that it potentially could be safe, and that is considered by the company as a physician decision. It is an appealable situation. I've done it maybe once or twice. As you know, the Europeans are very focused on cost, and they published this in Neuro-Oncology in 2019. This is not FDA approved in Europe because of the cost. The cost is $20,000 a month. And the Europeans basically said that the overall survival of 4 months was not worth the 185 euro price tag. It is used in Germany, Austria, Switzerland, Sweden, Israel, and Japan, but most of the users, as you can see, over 2/3, are in the United States. So, as with everything else in today's talks, there is the push to combine this treatment with other therapies, and of course, immune therapies are being considered as an adjunct to tumor treating fields. And why might that be a good idea? Well, if we believe the way in which tumor treating fields work, as we talked about before, this abnormal cellular division causes this blebbing of the cell membrane, and that creates increased binding and permeability across the cell membrane, making them potentially more susceptible to other therapies. And this is just a little schematic showing increased susceptibility of cells after being exposed to tumor treating fields. And again, these pretty mitotic pictures, again using a drug with an immune modulator showing the blebbing and the change in the mitotic activity with tumor treating fields and the drug in question. So, in summary, tumor treating fields act by exposing dividing cells to alternating electric fields, which leads to this microtubule misalignment. That this, according to some, maybe not always me, is a promising new technology for the treatment of locally advanced solid tumors, and I do strongly believe in using this modality in clinical trials. I'm just not as sure about how I feel about its place outside of clinical trials, despite the FDA approval, as we've discussed. Skin is the main toxicity, and we're working hard on expanding an understanding of the mechanism, and that I would say is the other problem with tumor treating fields. In a point-counterpoint at ASCO, I think just last year, they had 2 scientists get up to debate pro and con the science behind tumor treating fields, and both of these very well-known neuro-oncologists said to the audience, to be frank, I'm not actually sure that I believe that tumor treating fields act in the way that is shown here, because when they tried to get access to the information about how tumor treating fields worked outside of the articles that I've given to you, the majority of it is tightly controlled by the company. And many of those papers, if you look at the conflicts of interest are because most of the authors have some tie to the company, which, as you can imagine, I do not. So there is that issue as well, is that I'm not actually sure, despite everything that I've shown you, that we really know how tumor treating fields work. So with that, I will stop and move to the questions. Thank you.
So, question for you. Obviously, you're at a radiation oncology meeting.
Yes.
Does this treatment radiation sensitize? And how come there haven't been any trials looking at concurrent radiation with your device, at least that I know of? Are there any in the process? What do you know about it?
Well, how could you wear it and get radiation? Wouldn't that be really difficult, just for your treatment planning? I would think you'd get a lot of artifact.
No, you remove the device while you're radiating.
Well, then you're not actually radiating them when they're wearing the device. So
only
that's
it only
the thing
takes an
about
hour
Tumor
to
Treating Fields.
radiate,
The
so-
argument is it only works when it's on your scalp, that there's no activity, unlike systemic chemotherapy, there's no activity once it's taken off. But
So
it's a
if
great
you-
question, but I,
If you interrupt it for 20 minutes,
Yeah.
it takes me 15 minutes to deliver an SBRT field.
right.
I can't fathom why this hasn't been looked at.
Well, I think I may have alluded to some of the reasons, right?
Yeah. Okay, if you say so.
Oh, I did want to make one point for a radiation oncology audience, and that is, as you can imagine, because we're in Seattle at the University of Washington, and we have a lot of patients in Alaska, Montana, other side of the mountains, I'll frequently see and diagnose a patient with either glioblastoma or recurrent glioblastoma at the Alfred Brain Tumor Center at the University of Washington, and then I will refer that patient out to you closer to the patient's home. And then typically, it is our practice to see patients back 4 weeks after the end of radiation therapy to talk about what is the new multidisciplinary plan going forward. And I'm always really surprised and, to be truthful, a little bit upset when my patient walks through the door wearing an Optune device that their radiation oncologist has prescribed for them without a discussion with the broader team. And so I don't know if that's part of your practice, and it might make perfect sense, particularly if there's no neuro-oncologist involved, because this is not something a medical oncologist is likely to prescribe. But just out of my interest, how many of you prescribe Tumor Treating Fields for your glioblastoma patients as part of your standard of care? Wow. Okay. That's a lot. No, I know. That's obvious. Yeah, I know. That makes sense. Do the medical oncologists ever question it when you prescribe it? No?
Say that again. Did everybody hear who spoke? Just could.
Before I even see the patient for consult, they'll come to me being told by their medical oncologist that that's part of the treatment.
Part of the treatment that you're going to provide.
Mm-hmm.
And do you? Always?
Is there any meaningful difference between Optune and Novacure in terms of the way
No,
it
it's the
works,
same
or
thing.
Totally just different companies.
Yeah.
Okay, we'll go on
Yep.
to the SAM quiz.
All right, you are currently evaluating a patient with a glioblastoma who has recently undergone maximal surgical resection and concurrent chemoradiotherapy and is interested in Tumor Treating Fields. He wants to know how long he'll be required to wear the device every day, and you tell him that he's required to wear it a minimum of X hours daily to derive the maximum amount of survival benefit. That should be a gimme. Excellent. All right, question 2. Which of the following statements accurately describes the therapeutic rationale for the use of TTFields in the management of glioblastoma? Number 1, it's anti-angiogenic, disrupting tumor vascular supply. Number 2, it's an anti-mitotic therapy, disrupting tumor cell division. Number 3, it's a radiosensitizer with greatest efficacy when administered simultaneously with radiation therapy. Great idea. And number 4, it potentiates the immune system. And of course, it's an anti-mitotic therapy, which you all knew. Question 3, what is the most common adverse event associated with TTFields therapy? Pneumonitis, skin toxicity, hypertension, or peripheral neuropathy? And of course, 100% skin toxicity. They're pretty easy questions. Question 4, when optimizing the TTFields therapy, dose it for your patients with, oh, that one I took out later, but that's all right. What should you consider in customizing the transducer array if you were doing it? And we skipped over this, and I actually took this out of my up-to-date questions because I didn't think it was really something that I addressed adequately. But you can answer it anyway. I touched on one of them anyway. And the correct answer is frequency and power density, and that was from a phase 3 EF14 trial where they looked at higher TTFields intensity and power density to see how those impacted overall survival. But as I said, we didn't really talk about that. And the optimum frequency of TTFields for glioblastoma is 50, 120, 150, 200, or 240 kilohertz. Thank you. Get this thing off me.
Thank you, everyone. So we're running a little bit early, so I don't think you guys want a 30-minute break. Why don't we come back at about 10:20 for Dr. Yam's talk? So 10:20 for Dr. Yam's talks. We'll have a 20-minute break. Please remember, if you go out the back doors and across the courtyard, there is a supporter room for our supporters, and there's coffee and juice in there and where people can talk and meet the speakers.
This tech setup is unbelievable. I feel like Beyonce. So I have a touch screen, which I'm going to try to operate, and I think this talk's a little more maybe down to earth than some of the other ones. No high theory here, really. What we're just going to talk about is a pretty rare cancer that I think maybe doesn't get as much attention because it's a little bit unusual. We'll be doing some other talks later in the course that are a little more spicy and controversial and a little more cutting edge. But I actually do think salivary gland cancers are incredibly interesting because they are so diverse. And one of the things I'm going to stress during the course of this is that it's really, really important to understand the different histologies and the natural behavior. And this is probably one of the hardest areas for my poor residents to get over because they just can't believe there's so many different kinds and they can arise in so many different places and they can act so differently. So that's what gets a little confusing. I do have some disclosures to show you. This includes, I feel strongly about this, this includes all my non-disputed payments. This includes my clinical trial funding, which I receive from 4 companies, as you can see, as well as royalty payments that are paid personally to me, not to my institution, and this is for the past 3 years. So today, we're going to talk about salivary gland tumors, and I say tumors because not all of them are cancers. We're going to review principles of surgical management because, as many of you are probably already aware, the primary management and the right answer for a salivary gland cancer or tumor, if you see it, is surgery first, if at all possible. We're going to describe how we coordinate management of the regional lymphatics, which can be very confusing in salivary gland cancers. And we're going to talk about where IMRT can be useful. We're going to then go into the maybe the little bit newer areas of this disease, which are the novel approaches that are emerging in terms of chemoradiation, which is not standard of care at the moment, particle therapy. And then I'm going to show you some stuff from the metastatic disease setting. It's actually really important because there's been some tremendous development in salivary gland tumors within the recurrent metastatic setting, and I believe these will come very soon to pass in the locally advanced setting as well. So this is a rare cancer. It's actually formally defined as such by the NCI and falls under the Rare Tumor Task Force in the head and neck steering hierarchy. Less than 2,500 cases per year in the United States. And this is important. So there's a little rule of thumb I tell my residents, which is that the biggest glands, you can think about like this in terms of real estate geography, the biggest glands have the most cancer. So the salivary glands, there's the parotid, submandibular, sublingual, biggest gland has the most cancer, keep that in mind. So the parotid gland accounts for about 70% of major salivary gland cancers. With the lowest rate of potential malignancy. So it goes opposite in terms of your risk of malignancy. Most cancers in the parotid, lowest chance to be malignant, and then as you go to the submandibular and sublingual, your chance for malignancy goes up to 50%, but less of them overall in terms of number. And this is less than 5% of all head and neck cancers in this region of the body. There are, as defined by the World Health Organization, 24 different histologic subtypes of salivary gland cancers. And I strongly urge you, although I know this is kind of a pain and a painful recommendation for me to put out there, I strongly urge you, if there are questions at all, and many times there are, to have your pathology reviewed at a tertiary care institution. And I realize that that is a difficult thing to enact, but I will tell you that in our institution, these are the cancers where we overturn diagnoses the most. And in fact, but we probably have about several cases a year where we actually are in conflict with 2 other major institutions about the exact diagnosis because these are incredibly difficult to diagnose. We can sometimes diagnose with some specificity on FNA, but really you need pathologic specimen to be able to diagnose these, and it gets really, really complicated. So the picture did not come through on the slides, but what I was going to show you was the relationship of the parotid to the facial nerve and how that relates to what kind of surgery is done. So for a parotid cancer, 90% of the tumors, and this includes pleomorphic adenoma, which is benign, as well as malignant tumors, 90% of those will arise in what's called the superficial parotid. And if we had the picture, I would show you the anatomy, which is that the facial nerve actually runs between the superficial and deep lobes of the parotid. So when you have a tumor that's out in the superficial lobe, it's not uncommon that the surgeon, to do a gross total removal, will take off the superficial aspect of the parotid. But if the tumor is extending into what's called the deep lobe, sort of past that dorsal vein, you're going to get invasion that goes deeper than the facial nerve. And this is where the dissections become extremely dangerous to the facial nerve and also very complex to get clear margins. So that's when you actually look at the cross-sectional radiology, you can see the extent of that tumor into the deep lobe, and that's going to be critical for determining what type of surgery. Many people show me scans after parotidectomy, and they say, I still see parotid there. It's like, well, that's okay, because honestly, if the tumor is completely confined in the superficial, they got it out with clean margins in a superficial parotidectomy, that's actually kind of okay. You don't have to take the whole parotid because they made a decision to preserve the facial nerve. I hope that makes some sense. About 14% of these cases will present with a clinical facial paralysis and or skin involvement, and for those cases, you're really talking about a sacrifice of the facial nerve, paralysis of the face, and a major reconstruction. And so for those patients, again, they have to be counseled up front about what you're going to do with the surgery itself, which is to take their facial nerve and sacrifice a large amount of tissue, and also what the radiation is going to do, because in this case, most commonly the radiation is going to extend up into the brain to the base of skull, and there's almost a near certain risk of hearing loss. And then the extended parotidectomy, these are for extremely advanced cancers. This is very rare, unless you're talking about a very aggressive kind of squamous or adenocarcinoma. I have not seen this a lot, but these parotid cancers can sometimes go into the masseter or mandible. Now, in the case of submandibular cancers, sublingual cancers, or minor salivary cancers, the standard of care is just a wide local excision and then an adapted neck dissection, depending on the histology and the layout of the cancer geographically. But these cancers, in my experience, I have not seen them go to the sort of aggressive level of the parotid cancers. These cancers often tend to extend along planes within the floor of the mouth or within the buccal or lip mucosa, and they don't tend to require these huge reconstructions. A wide local excision is fine for that. And we're going to talk about the nerves that can be involved there. So I think the really difficult issue for salivary gland cancers is not radiation to the primary. We can talk about radiation to the primary and what merits radiation to the primary, and that's not a very difficult decision. Frankly, almost all salivary gland cancers will get radiated to the primary unless they are an exceptionally wonderful low-risk cancer, either benign with totally clear margins or intermediate prognosis with almost no risk factors. But that is so rare. I can say in my experience, it's been a handful of cases where we haven't radiated the primary. The real question is what you're going to do with the neck. And so these are a couple of recent papers that use multivariate analysis to try to figure out what we could do to subdivide these patients by risk. And you'll notice that these aren't prospective studies, and the reason for that is because there are practically no prospective studies in salivary gland cancer. It's too rare. There's too many different histologies. They get confused very often with skin cancers when they're squamous or muco-ep. So they're very, very difficult to design clinical trials around this. So what you'll notice that both of these studies revolve around advanced stage, which I would call, major nerve involvement or T3, T4 staging, or very aggressive disease in the neck, like extranodal extension or lymphovascular invasion or perineural invasion. Okay, so those are pretty standard indications. And then, of course, close and positive margins goes without saying. But this is the real key, is the high-risk histology. So this is why almost all salivary gland cancers of any aggressiveness will eventually get radiated. I'm going to read them out. Mucoepidermoid carcinomas, salivary duct carcinomas, adenocarcinomas, squamous cell carcinomas, which again, mucoeps and squamous can often be skin cancers, so you have to watch out for that. Oncocytic cancers and ACC, and I'm going to add to that myoepithelial cancers as well. So all of those histologies essentially merit radiation therapy. And when you get, and maybe the mucoep at low grade is a little bit of a questionable category, but when you include all of this, you're really talking about almost all cancers and all of those of advanced stage. There's some argument that we could use molecular factors to parse this out more, but that really has not been established. And this is just a chart showing you some of the major series in salivary gland cancers and where the highest risk to the neck occurs. So here we're talking about occult nodal metastases. That means patients who've had a surgery, and then we analyzed the pathology from the surgery and figured out who had actual disease microscopically present in the neck. And it was very, very high for those that had anaplastic or salivary duct types of histology. For squamous, or what they call epidermoid in these series, it was lower. For adenocarcinoma, it was a little bit lower, and then you get into the high-grade muco-ep adenocarcinoma type of category where you're really talking about just barely over the risk level, where we would talk about radiation therapy. So the question here is, when the surgeon goes to operate on this salivary cancer, are they going to operate on the neck? And that is determined by the risk here. And I would say that these cancers that I've highlighted, you're going to get at least a supraomohyoid, or what's now known as a selective 1 to 3 neck dissection. And then the question is, do we need to radiate that as well? And then the low-grade cancers, where it's a very questionable whether the neck needs to be addressed. So malignant mixed cancers, or what's known as pleomorphic adenoma or carcinoma ex pleomorphic adenoma, adenoid cystic, where the risk of nodal metastases is quite low, and then actinic cell, and there's also sort of a basal cell carcinoma type that's very similar to actinic cell. So we're talking about basically kind of 3 categories of very, very high, intermediate risk, and low risk, which is a useful framework whenever you're talking about post-operative therapy. So for a cancer that has intermediate or high risk, most surgeons, as I said, will dissect selectively into the neck. And they do this by anatomic patterns, as many of you might know. So for submandibular, sublingual cancer, the selective neck dissection will encompass levels 1 to 3. And if there was clinical involvement or radiographic involvement that was identified prior to the surgery, meaning it was clinically positive and it was a therapeutic neck dissection as opposed to elective neck dissection, they'll extend that dissection out to 4 or 5. Same goes for the parotid, except you'll notice here that in the parotid, the drainage is coming down into levels 2 to 4. So very logically, the elective neck dissection is covering 2 to 4, not necessarily 1 and not necessarily 5, unless there was clinical involvement. And what I want to say is that it can be that a patient is, I've had this situation, a patient is dissected, has their primary tumor taken out, was thought to have a low-risk histology. Turns out that histology is actually high risk. On scanning or repeated ultrasounds of the neck, there is no evidence of clinical nodal involvement. It is reasonable to talk about substituting elective RT to the neck as well. And in fact, in the retrospective sort of biased surgical series that are out there, it's been shown that you can do that. And I've had a couple of surgeons I've worked with who've actually preferred to do it that way. They take the primary out if it's lower intermediate risk. They cover it with elective RT to the primary and the neck afterwards. That is not unreasonable to do. Although I'll say, kind of driven by the oral cavity excitement about selective neck dissections, more and more of these selective neck dissections are taking place. And one more thing I'm going to just say about this is that you'll notice that the retropharyngeals are not included here. That's an important distinction. When you radiate these patients, remember that these patients are draining primarily to the outer neck, to the cervical levels of the neck. By sparing the retropharyngeals, which are not typically involved by salivary gland cancers or skin cancers, you're saving the patient a lot of pharyngeal dose. So just remember that. You do not cover the retropharyngeals. And so you only need to cover to the medial aspect of the carotid. You do not need to go further into the pharynx. And that's actually kind of important because these patients are mostly going to get unilateral therapy, and you want to obviously spare them some toxicity there. The other little hint I'll give you here is that you'll notice that we try to, when we radiate the parotid, we try to stay out of the ear. And I'm just going to say that something to think about independently is how your primary tumor coverage is going to interact with your nodal coverage and what that connection is going to be, and how you're going to curve around the bottom of the ear in particular and the cartilage there, because you can get a lot of cartilage inflammation, which is quite painful to the patient, as well as injury to the EAC itself. And this gets really, really difficult around the parotid. Okay, so what about the primary tumor? The primary tumor, like I said, is almost always going to be treated. It's much easier than the neck, and here's all the indications. So you have all those histologies that have to be treated. You have all these indications for adjuvant radiation to the primary. You can see how very few salivary gland patients are ever going to escape from adjuvant radiation therapy. So closer positive margins, high-grade histology, like we talked about, advanced primary tumor stage, invasion into adjacent structures like the muscles or the bone, the masseter or the mandible, lymph node metastases, lymphovascular invasion, tumor spillage. This is very common for, as you know, pleomorphic adenomas, where the capsule is sometimes fractured at the time of removal. Gross residual disease, which is sometimes common for inexperienced surgeons who are dissecting around the facial nerve. Deep lobe involvement, and the reason for that is because you almost always are talking about tumor invasion around the facial nerve. Perineural spread, which is adherence or invasion of the cranial nerve 7, which is the facial nerve. Histologic evidence of major perineural invasion or minor perineural invasion of extensive category, and then recurrent disease. Recurrent disease is a difficult one, particularly in very young patients who've had a salivary gland tumor that was resected and they were fine, and then they recur several years later, they have another salivary gland tumor, and they're young. But often the justification here is to preserve the facial nerve because a further recurrence in a dissected neck that's been twice operated, that will be a very, very difficult situation to try to preserve the facial nerve again. So that's the discussion, I think, when it comes to this recurrent disease situation. And we follow what I showed you now, which is the surgical indications, which is if they're just low grade and N0, but they have a high risk for recurrence, it's just the salivary gland bed alone. If they have very extensive perineural disease, you consider treating up to the pterygoids. If they are high grade or lymph node positive or recurrent, now you're going to cover the tumor bed, the ipsilateral neck. If they have perineural invasion, you're going to cover the facial canal at least to the geniculate ganglion. If it's positive margin on the facial nerve or very extensive perineural invasion, even with clearance of that, you may even cover into the IAC, to the cranial nerve root. And then for sublingual or submandibular cancers, you have to look at coverage of the lingual and hypoglossal nerves if there's a lot of perineural invasion. And then we do a boost to the tumor bed for close and positive surgical margins. At UCSF, we use 60 gray for most standard cases. We go to 64 or 66 for close versus positive margins. So one thing is when IMRT is required, and so I'm putting this in here for those of you who have to fight for your authorizations. We rarely get pushback on salivary gland tumors anymore, but sometimes when you're dealing with a more rare one, you will get that, especially if it's in an unusual location, such as the buccal mucosa or submandibular gland, which they're not familiar with. And I think it's really important to emphasize what you can spare with IMRT. And there are planning studies that show that you reduce dose to the cochlea if you're able to spare that last segment of the facial nerve, assuming it's not involved, frankly, by tumor. You can spare the brain. This, again, is specific to parotid cancers. If you're having to track up from a submandibular, that's true as well. You can spare the oral cavity. That's true for submandibular and sublingual cancers. The contralateral parotid and spinal cord, of course, always go along with IMRT, or really any form of unilateral therapy. And then IMRT is really important when you're covering perineural routes of spread or deep-seated tumors. So if there's a patient of mine who has a tumor where I'm concerned about invasion, frank invasion into the lingual nerve and the branches of 5, or the 7th nerve and the branches of 7, I will say this is a patient who has actual central nervous system invasion, right? And then there's no arguing with this. So talking about perineural spread, there is named nerve invasion and no named nerve invasion. These are the classic sort of categories. For the parotid gland, we've talked a lot about the facial nerve. Like I said, it's almost standard with any level of perineural invasion to cover to the geniculate ganglion. But we will cover past the geniculate ganglion, and it's not infrequent at all that I take patients all the way to the cranial nerve 7 root. And that's really an important thing to keep in mind. I try to figure that out before I have the consultation, because you have to have a pretty serious discussion and document the loss of hearing on that side if you're going to do that. It is impossible to track the facial nerve all the way in without damaging the cochlea. And then the submandibular gland cancers, for those we look at the lingual nerve and the hypoglossal nerve, and if there's very, very extensive minor invasion, which I define as more than 4 areas of microscopic invasion or a large caliber nerve on pathologic review, then we go all the way up to the foramen, which are the ovale and the hypoglossal canal. And if there is no named nerve involvement, it is still worth talking about coverage up to the pterygoid fossa, just because that is such a common place for spread. It's easy to prophylax at a lower dose, and furthermore, with extensive perineural spread, you may just not have caught what was named and what wasn't. I want to show you an example of intensity modulation and another justification for it besides perineural invasion. There are these very high-grade salivary gland cancers that can invade at the skull base. And there's all different kinds of histologies you can find up there, but this happened to be an adenocarcinoma. And it's pretty clear that you can't treat these kind of cancers to 70 or 74 gray without the use of intensity modulation, and that's what we did. And I also want to tell you the story of this patient because I think it's very informative. We treated him to 70 gray. He actually got essentially a complete response with resolution of all of the tumor within a couple months of treatment. He was disease-free for about 2.5 years and then relapsed massively right at the same spot along the right infratemporal fossa. So just to give you an idea of what IMRT can and cannot do, and I'm very realistic about that with patients when they have inoperable salivary gland tumors of any site, that what we can do with radiation is great, but there are serious limitations to it. The general thought process from the older literature is that with radiation therapy alone, you can maybe achieve about a 30 or 40% local regional control with the use of concurrent chemotherapy at the same time this patient receives cisplatin. So, I think that's a very good sort of back of your pocket number to cite to patients who are inoperable and to be realistic about it. There was a study that was run by the RTOG MRC a long time ago, and I'm guessing there's people in this room who might actually remember this study and were around when this study was being run. And it was a small study because back then, people didn't really do the big controlled studies like they do now. So it's got some limitations. 32 patients were actually randomized, so that was a major feat at the time, between neutrons and protons. Only 25, and you'll start to see here some of the problems with the study, only 25 were evaluable. All of the patients had inoperable or unresectable recurrent salivary gland tumors, and all histologies were included, which is another weakness of the study. So there was an imbalance between the arms in that more of the squamous cell carcinomas, which we know are very resistant and difficult, went to the photon arm. More of the mucoeps and actinic cell, which tend to be a more benign acting type of histology, went to the neutron arm. The local regional control was significantly different, with the neutrons showing a very significant difference at 56%, which, as compared to the historic numbers I gave for photons, is impressive. Versus 19 for the photons. The overall survival was not different, and why was that? Because distant metastases were the primary driver of death in this study, and there were in fact more distant metastases and more death in the neutron arm. And then the other thing to talk about is that there were more severe late complications with neutron therapy, meaning grade 3 or higher. I think some of us who have followed neutron patients at very long-term follow-up have seen some of this with necrosis of tissue, and I have a couple patients where various structures have collapsed as a result of neutrons at very long-term follow-up. So it's not a trivial thing to buy this improvement in local regional recurrence. And so when the NCCN came together to talk about this, it was a very anguished debate as to what we should do about neutron therapy. For those of you who may not know the inner workings of the NCCN, we have a 5% rule. So if a treatment is being used, which is hard to take for us because we're sort of specialize in exotic therapies in radiation oncology, but if a treatment is being used for less than 5% of that named population, it is not recommended by the NCCN because it is not able to be used nationally and internationally according to guidelines, and it's not appropriate to give guidelines to people that they can't follow. So the 5% rule, we actually did a little census, a little survey of who was giving neutrons and who wasn't, and it turned out that only the University of Washington at that time was still providing neutrons. Their program has considerably scaled back, I understand, because they're now using proton therapy a lot. So the NCCN recommended against it as a general recommendation, although we did leave a little bit of an escape route there saying that we recognize the value for select patients. And that's been a very controversial decision, but the fact is that neutron therapy is not something that's available to many patients, right?
And that brings up the question of particle therapy in general and how we talk about particle therapy in relation to this difficult question of what we call radio-resistant cancers, right? Is there a role for particle therapy in cancers like this? I'm just going to show you, this is a slide that Nancy Lee keeps telling me is outdated and I shouldn't use anymore, but I like it, so I'm going to use it anyway. This shows the 6 gray line for proton therapy treating a salivary gland tumor. And I just want you to notice that, you know, how the unilateral therapy and the 6 gray really combine to give a lot of conformality. As many of you know from treating unilaterally with standard IMRT, you'll typically get about a 20 gray washout line that comes across almost the whole body, right? At least 15 or 20 gray to the other side. So 6 gray like that is actually, you know, you have to give something to that. That's quite impressive, right? And especially if you're talking about a younger patient. What did the NCCN decide about this? Well, the fact is that there's been no quantification of the clinical value of this. It's a limited number of patients again. The availability of proton therapy remains sort of, I would guess, non-uniform across this country. So the back out here in the NCCN level for all proton therapy at this point in head and neck cancer, and we can talk about it in other sites as well if you're interested later, is that you can consider using proton therapy when normal tissue constraints cannot be met by photon-based therapy. And I'm actually eager to hear what people think about that, because maybe using the baseline of normal tissue constraints isn't enough. I mean, maybe we should be saying that who has better tissue constraints, right? I mean, what defines what is a normal tissue constraint and what should and should not be covered by payers in this country? But right now, that's where we are, and I'll tell you that that was a very, very hard-won concession from the surgeons and medical oncologists on the NCCN. So that's where we're at. I will say I've personally sent 3 of my patients for carbon ion therapy in Heidelberg in Japan. And why have I done that? Because I do believe that there is utility in these treatments for patients who have the means and ability and have truly unresectable cancer. So this is just some data that actually has been published by the carbon community. You may be aware that carbon ion therapy, I had a little diagram in here which doesn't seem to have made it, but there's a little diagram just showing that carbon ion sort of combines characteristics of protons along with neutrons, and that it has that high LET and it has most of the stopping power of protons, okay? So it kind of combines that very, very sort of killing power of the neutrons with a lot of the conformality of the proton therapy, although not perfectly so. And so this has been of high interest in Europe in particular. The COSMIC study, which was a phase 1 study that was basically done to collect data in Heidelberg, the combined treatment of malignant salivary gland tumors with intensity modulation therapy and carbon. They do a combined tomotherapy with a carbon ion boost at the end, produce a 3-year local control of 82%. And I have to say for this tumor, as you just heard, that is a very, very impressive number. And the J-Cross study, which was basically a retrospective study of 69 patients, showed a similar finding of 3-year local control of 81%. So, I will just say I've sent a couple of my patients for this. They've done actually really well with it. One of them has developed distant metastases, which have been controlled with SBRT, and he's almost 7 years out. So what else can we do in the United States, since we don't have any carbon ions here? RTOG 1008 is a randomized study that is still accruing. I think they're just finishing up the end of the phase 3 now. I'm going to say there's a lot of issues with this study. So one thing you'll notice right off the bat is they didn't include squamous cell carcinoma. And why did they not? Because they felt that the majority of squamous cell carcinomas in the parotid were likely metastases from skin cancer, and that would not be appropriate to get them mixed up. And at the cooperative group national level, that would be a high risk to the study that you would be confounding that. So they excluded squamous cell, which took out a whole bunch of the eligibility. They also took out the low grade and what some people classify intermediate grade mucoeps, although that's very controversial, but they took those out as well because they really wanted to focus on the ones that had the highest risk for metastasis. And so that leaves you a very select population, but nonetheless, they have managed to accrue. They're getting there. I expect they'll be done in the next maybe couple years. Basically, this is a randomization with and without cisplatin. And I don't have to go through all the literature, but I can just tell you that there have been a number of retrospective reviews, NCDB analyses, we all know what those are worth, kind of complicated literature there arguing that chemoradiation is beneficial for these patients. Very unproven at this point. My own personal experience is I've put very, very high-risk patients on both arms of this study. It's not clear to me how it's going to end up. Sometimes I can predict, but I can't predict on this one. Now I think I'm going to shift for just a second and talk about some of the emerging therapies in salivary gland cancer. And while I realize that this is a radiation oncology audience, and some of this is just going to cause you to glaze over and get frustrated with how much money this all costs, it is really important because, as you've seen, our results with salivary gland cancer in general are okay, but not great. And one of the major causes of death now in these patients, especially SDC, or salivary ductal carcinoma, is distant metastases. So this is a real problem that we have to work on. And there are very, very few people in the medical oncology community who even want to work on this because it's such an obscure disease, so you have to give credit to them for trying. The first one we're going to talk about is adenoid cystic carcinoma. So many of you may be aware that adenoid cystic carcinoma has a natural history where we control it and it metastasizes somewhat inevitably, if it's advanced at all, to the lungs or the bones later on in life. And these patients can have a very long natural history. I think my all-time record is we have a patient at UCSF. I didn't treat her the first 2 times. I treated her the last 3 times. She's been radiated 5 times. She's still going. She's like 18 years out from her original diagnosis, living with distant metastases in multiple organs, and looks good. So this is kind of the way we think about it. If you're really interested, you can go dig up my paper on recurrence, which is, I think, the only one that documents that kind of history. But it's a very interesting natural history. These patients have a very poor response to chemotherapy. Their overall response rate to paclitaxel and gemcitabine is 0. I mean, it's really hard when you see 0, okay? Gemcitabine cisplatin does a little bit better, 20% overall response rate. That means any response. You can see that they've tried some other things like HDAC inhibition, some of the TKs like sorafenib, lenvatinib, apatinib, all relatively poor, although maybe some possibility with lenvatinib and apatinib. And there was actually a phase 2 trial that was published. Oh, this is the same slide. Well, anyway, phase 2 trial that was published in lenvatinib, which actually shows a sort of promising response rate. And lenvatinib is now considered, because it's actually been published and discussed and peer-reviewed at this point, and has the highest overall response rate so far in this cancer, that for patients who are in true dire distress from their adenoid cystic, can't be managed by aggressive local therapy anymore. Lenvatinib is an interesting and possibly the most active agent at this point. I will note that in this study, 18 out of 32 patients had to be discontinued from drug due to toxicity. I don't know how many of you have had the privilege of working with lenvatinib or Lenvima in the thyroid cancer setting, but it causes a lot of hypertension. It can be very difficult for patients to tolerate over the long term. So one of the problems with adenoid cystic is that it is very slow growing. As you saw, it does not respond to chemotherapy, and there's only one validated cell line of adenoid cystic. Most of the adenoid cystic cell lines have found to be contaminated and not truly adenoid cystic, so there's no experimentation that's possible. There is a fusion protein called MYB, but it's a major active transcription factor in the disease, but it's difficult to target, and the only downstream target that's commercially possible is FGFR, which is not really being developed at this point for this disease. A new interesting possibility in the future is PSMA. PSMA, or prostate-specific membrane antigen, is expressed in adenoid cystic as well as many types of salivary gland cancers. And I will just say we're very interested in this, as are some other centers, trying to do PSMA imaging. If you ever do a PSMA scan on a prostate cancer patient, you'll notice that the salivary glands take up a huge amount of the tracer. So there's clearly something in that relationship that's worth exploring. But there are not yet any targeted agents therapeutically developed yet for PSMA. AXL receptor is being investigated in adenoid cystic carcinoma, but these agents also have some considerable toxicity, and remain in clinical development. And then I wanted to just bring all this up because I wanted to talk about immunotherapy. Adenoid cystic carcinoma has a relatively low tumor mutation burden, among the lowest, even among the salivary gland tumors, which tend to be low, like half of that of some of the other common cancers you might think of. And there was actually, because of this low tumor mutation burden, it's thought that that explains the discouraging results with immunotherapy for this cancer. And I will just say that before some of this data started to come out, my medical oncologists were putting a lot of adenoid cystic cancer patients. We have a large survivor community at our institution. They were putting them on immunotherapy thinking it would help because it helps with everything. And of course it helped because they don't grow and it's a slow disease. And so they looked fine. 6 months later, it's like, oh, wow, stable disease. It's like, yeah, they had stable disease. They had stable disease before. So it doesn't prove that immunotherapy does anything for these patients. And there was actually a SWOG trial which was a dual CTLA anti-PD-1 blockade for all rare tumors. And within the cohort of adenoid cystic carcinoma, the overall response rate, now this is response, right, was 4%. Okay, so actually produce, and that was with Ipi-Nivo, which is, as you know, a higher toxicity than Nivo alone. So that's overall response rate is low. Of course, you can achieve stable disease. It's unclear what stable disease means in the context of this disease. The more challenging and difficult cancer is salivary ductal carcinoma. These cancers are highly metastatic. The survival is much lower than any other form of cancer because of their distant metastasis rate, and they can be extremely aggressive if you've ever dealt with one of these. They're also often adenocarcinomas. What they've recently found is that many of these, about a third of them, are HER2 amplified. So that obviously is extremely interesting because if they're hormonally responsive, we have good therapies for that. So there have been 3 studies, as you can see, that have been published or presented on either immunohistochemically positive for HER2 or FISH positive for HER2, showing response rates of upwards of 70 or even 90%. So that is really tremendous for this particular group of patients, and for that reason is highly endorsed at this point within the medical oncology community. And the drug that's commonly used for HER2 positive disease, as you may know from the breast cancer setting, is trastuzumab or pertuzumab. And then salivary duct carcinomas, again, being this kind of very interesting cancer that appears to be driven a little bit more by specific expression, is also shows very high expression of androgen receptor. So again, a hormonal manipulation of these cancers. And that's why, you know, I'll just say in the real world, that's why this is so exciting for us, because when we have these patients who've recurred after treatment, or who have, I will just say, kind of leaning over a little bit, when they have extremely aggressive disease that we're trying to treat adjuvantly and cure, we do talk about hormonal treatment for these cancers because, you know, it's a lot easier than chemotherapy. And it's very well tolerated by the patient. So that's part of what's so attractive. And the androgen receptor is overexpressed in about 70 or 80% of salivary ductal tumors. It's also seen in quite a number of adenocarcinomas that haven't quite reached the level of salivary duct. And this is just a bunch of, you know, little studies showing various levels of response rate, but basically the overall response rate is not clear with AR blockade, since it's ranged anywhere from, you know, 30 to 40%. But then the one prospective phase 2 alliance trial that was done showed an overall response rate of only 4%. So that, you know, that trial, which was a little bit confusing, included a lot of patients who'd already had ADT. So there may be some contamination of the effect there, but still it appears that the overall response rate is moderate. And then there has been some data coming out from Europe showing that patients who receive ADT, androgen blockade, seem to live longer and do a little bit better. And also, very importantly, that they respond to androgen receptor even if they are HER2 positive. So in a patient who's androgen receptor positive and HER2 positive, many medical oncologists now will try the androgen receptor first in the hopes that they can preserve the HER2 option for later with the better response rate. And then there's an EORT study right now that's actually studying this, which is looking at 2 arms of platinum-based chemotherapy versus GnRH. and bicalutamide. So current recommendations right now, and I do think this is actually important because I suspect that this will all start to filter down into the local regionally advanced setting pretty soon, given the very impressive response rates to HER2 and androgen receptor in particular. So for salivary duct cancers, we look for precision targets at my institution. For HER2 positive, like I said, we will initially start androgen blockade, but we may consider the backup of trastuzumab later on. For androgen blockade, we will go ahead and start leuprolide. Oh, sorry, I have a typo here. For HER2 positive only, but not androgen positive, we will start trastuzumab. And there are a couple other things to mention. We talked about adenoid cystic carcinoma and the role of lenvatinib, or given its modest response, a clinical trial, but not chemotherapy and not immunotherapy. And there is one other that I'll throw out there, which is laronectinib. This has been shown to be sort of pan-cancer effective for any tumors with a TRK fusion. This is basically a very aggressive form of fusion alteration, and you can inhibit it with laronectinib. This has been FDA approved, and it's shown to be active in a very specific type of salivary gland cancer called secretory carcinoma. So those are the important things, but the message I really want to leave you with is androgen blockade and HER2 positive targeted treatment for salivary gland tumors, particularly STCs, salivary ductal carcinoma. And my summary slide is gone, so I will just summarize things for you. Okay, so for the majority of salivary gland tumors, the primary treatment up front is surgery, followed by post-operative radiation therapy, adapted to consider things a little bit differently. I consider salivary gland cancers and skin cancers kind of interesting in that we bifurcate the primary site and the nodal region, and you decide how you're going to treat the primary site, surgery radiation, and the nodal region, surgery or surgery radiation or radiation alone. And then, of course, you have to pay attention to the ideas of the facial nerve and the primary tumor extent, as well as potential tracking upwards into the skull base. What were the other points? Let's see. My other conclusions were, the natural history is very important to understand in terms of the risk of distant metastases, and whether the adjuvant therapy setting will evolve or not to include either chemotherapy or what is my prediction, more likely some of these targeted therapies. Immunotherapy does not look super great at this time, given the low overall tumor mutation burden that's been found in these cancers. And then we can talk about the emerging forms of novel radiation therapy, such as, well, our old dog, neutron therapy, which unfortunately just has not proven itself to be viable in the United States, versus the potential for carbon ion, which I think the effect there will be limited in terms of reduction of toxicity as opposed to therapeutic effect. And then carbon ion therapy, where therapeutic effect actually shows some potential signal. Unclear whether that will ever become a standard recommendation in the United States for unresectable tumors. And then finally, precision targeting in the future for some of these cancers, specifically salivary gland carcinoma, salivary ductal carcinoma. Anybody got any questions about any of that? Huh? I have my clicker. Oh. Yeah, I wanted to, okay, so I designed the questions kind of as questions/discussion, so we can talk about them a little bit as we go through them, because they kind of highlight specific points. Oh, we have a question. Oh, sorry. Okay. Yeah, go ahead. I think we have enough time to. Sorry? The non-medical complication rate.
Yeah, complications of neutron.
Yes.
When I ask George Laramore, he bends out of shape when I talk about it.
Well, okay, so they, part of it is that when they first developed neutron therapy, the actual planning software was pretty primitive, and they were doing it with really what was a very, very pure sort of, you could almost call it kind of 2D type of technique. So I think the complications we see at very late follow-up are in part due to that, right? And nowadays, they have a more sophisticated planning system where they can control the doses a little bit better. And I've been assured by multiple people from that institution that that is the case and that they don't expect to see the complications in the future. But, you know, I'm going to say that it's a difficult thing to work out given the proximity of these tumors to critical structures. I mean, for example, you know, many unresectable salivary gland tumors arise in the larynx or the base of skull. And so you're either near to critical swallowing structures or critical neural structures. And you know, there's a real concern there. The fact is that neutron therapy does not have the conformality of photon therapy or carbon ion therapy. That's just going to probably be what happens. But I do think they're probably doing better now. Unfortunately, it's not a question that will ever be explored given the state of neutrons in the United States.
So I had a patient that had a salivary duct carcinoma with androgen receptor positivity.
Oh, cool.
She was non-metastatic, and so she got post-operative radiation. We started ADT. The question is, how long do you keep them on the ADT?
Yeah, I don't think anybody knows that. That's part of why it's not, well, it's not the standard of care. So in the adjuvant setting, you know, it's really only been shown to have, like where we're at with all of that is that there's a response rate in the metastatic recurrence setting, right? And we don't have any guidelines to start it in the adjuvant setting. I mean, I applaud you for doing it and trying and doing the best you can for your patient, because that's also what we've done for very aggressive cases, to be really honest about it, but it's not part of the guidelines. And there's no way to know how long they can tolerate it. I will say we've had some patients that just couldn't tolerate androgen deprivation either, right? I mean, it does become intolerable for men after some time. So it's, you know, I think it's a judgment call on how long they can do it. In our patients, you know, when we've started it adjuvantly, we've done a year. But that's not like, you know, this is really like we're talking about a handful of people that happen to be tested and, you know, went on. Yeah.
Can you tell me what you do for the squames for the metastatic epithelials?
The squames, you mean metastatic to the
parotid? Yeah, for skin cancers that are meted to the you said the squames is the metastatic epithelials. What do you do for those patients?
Oh, yeah. So I don't think we have a skin cancer talk, which is too bad. So that's a very common site, as many of you know, from the vertex scalp or the temple, right? To go to the parotid, that's like the classic presentation. And you know, the data's pretty clear. I would love to give a skin cancer talk sometime if you want to hear more about it. But the data's pretty clear that combined modality therapy, surgery, and radiation is superior to either one on its own. So you should, you know, similar to salivary, that's why surgeons love salivary gland cancers and skin cancers. They just love them because surgery is always the right answer if you can do it. And so they'll do the resection, superficial parotidectomy. If there is an involved node in the parotid, the patient automatically gets a mandatory neck dissection, usually selective. And then we follow with radiation therapy. Now, the interesting question there in the evolution is that there are now 2 phase 3 trials, both commercially sponsored. One sort of half sponsored by T-ROG, but both commercially sponsored in essence. And they are both testing the addition of PD-1 therapy in the adjuvant setting for very aggressive tumors, advanced T-stage, perineural invasion, close margins, stuff like that. But anyway, the drug that was approved, FDA approved for metastatic recurrent squamous cell carcinomas of the skin, cutaneous origin, is cemiplimab, and that is a PD-1 inhibitor. So that's one of the ones that's being tested in the adjuvant setting after radiation therapy is over, similar to the Pacific lung trial. So they go on for a year afterwards. Kind of unclear to me how that's going to work out, because I'll be really frank, my experience is that with good surgery and really well done post-operative radiation, taking into account all the areas that maybe were not completely removed, because it's very difficult to remove them when they have perineural invasion or infiltrative margins. But anyway, you know, a good post-op radiation therapy, I mean, the control rates in the literature are like upwards of 80% for most cases. So it's you know, it'll be hard to improve that with the addition of further adjuvant therapy. Does that answer your question? For unresectable cancers, I'll just say that is a very interesting area to me, unresectable skin cancers and what we do with those. And off-label, you know, we've been giving them, declared them frankly unresectable, try to give them immunotherapy up front to see if we can induce a response. And get some sense of the responsiveness of the disease and whether they're going to metastasize or what. And then we'll often try to deliver a radiation therapy afterwards in combination with that, very similar to kind of an oligometastatic paradigm, or give them limited surgery if it's a really exceptional responder.
I don't see any other questions.
Skin cancers have a very high
one question over here.
Skin cancers have a very high TMB. Skin cancers have among the highest tumor mutation burden in the literature. So skin cancers are exceptionally responsive to immunotherapy as opposed to salivary gland tumors. So it's a very important distinction, and that's why, for instance, the RTOG trial or other trials exclude squamous cell carcinomas of the skin.
I don't know if you saw in the news recently, but Mayo Clinic Jacksonville's building a carbon ion therapy machine.
Yeah.
Next 2 years, we'll
Yeah,
send it to Japan
yeah, I
anymore.
did see that. I saw that on Twitter. Oh, Mayo Clinic in Jacksonville has contracted to build a carbon ion center, and of course, as everyone knows, Stanford and UT Southwestern have been in some negotiations, but an active operating carbon center has yet to, show its face in the United States.
So
I think MD Anderson is trying to get one too, right? Yeah, something like that.
if there aren't any other questions, I wanted to just remind you a couple of things on the clickers for the SAM credits. When you make the selection, it shall show up green just for a little while and then turn off. If you see it turn red, it did not record your answer. And there'll be on the bottom right-hand side, there's a timer as it does a countdown. During that time is when you need to have your answer recorded. If for some reason you're not sure, you're concerned about whether or not your answer gets recorded, let me know, and we can double check things to make sure things worked okay. Anything else we need to say on that? Okay.
Thanks for a great day.
Thank you.
Really enjoy this conference. I think it's just a really great mix of learning and fun. Okay, so where do the majority of salivary gland cancers arise? And you remember we talked about the rule that you can use as a rule of thumb, which is that the larger the area, the more likely it is that a cancer will land there, versus the increasing possibility as you get smaller and smaller that the cancer would become malignant. So with that, you can take a look at that. One thing I'll just say is that minor salivary gland cancers and ceremucinous tracheal cancers are exceptionally rare. Less than 1%. Do I get credit? Should I answer it? Okay. I got to get my SAMs. I'm going to get unboarded or I won't be able to answer those questions. I have I know I brought it up here for that reason, because Joe didn't have his. Oh, yay! Okay, good job, everybody. Okay, so we talked about the fact that these are rare cancers in general. 70% occur in the parotid gland. 20%, you can use that rule, kind of occur in the other types of glands, like the other major glands, like submandibular, and even less in sublingual. And only half of those are malignant. Versus the minor salivary gland, where up to 75% of them can be malignant. And the most common sites for minor salivary gland cancers are the soft palate, hard palate, buccal mucosa, all along the side of the mouth, and the lip regions, both upper and lower. And I was surprised, actually, no one brought up the really difficult question of what you do with a completely resected minor salivary gland, or ACC, in the lip, which is completely resected, has no negative features, and do you irradiate or not? It's very controversial. We just go back to our basic principles of how burdensome it will be to the patient's age, and what the morbidity of the treatment is. And then sublingual and tracheal cancers, like we said, are very rare. Okay, well, you can go read that. Which of these salivary gland histologies is the most likely to metastasize to the neck? And remember, we talked about how we're trying to develop therapies now to address the distant risk of some of these more aggressive histologies, right? The ones that are a lot harder to control. The more benign types of histologies versus the intermediate or higher risk histologies versus the very aggressive histologies versus the ones that have very long natural history and may not be responsive to distant therapy at all. So that should give you some help there. Oh, you can, oh yeah, sorry. He's not counting my discussion, so you guys are getting like 25 seconds. This is great. And is everybody okay? All right, so we talked about the need for better therapies in SDCs or salivary duct carcinomas, because while we can control salivary gland tumors really well, these have the highest propensity to manifest with very aggressive lymph node metastases, rapid aggressive metastatic spread. Pleomorphic adenomas are benign until they become an XPA or X carcinoma, X pleomorphic adenoma. They're not malignant. Actinic cell carcinoma is very, very low rates of metastasis, like less than 5%. Adenoid cystic carcinomas, like we talked about, has the long natural history. And mucoepidermoid carcinomas are mixed in their profile. They can be graded low, intermediate, and high. One thing about salivary duct carcinomas, I'll tell you a story. I had a very young patient. She was a tech executive, only about 30-something years old. And we had actually controlled her whole neck, and then she would just begin to develop dermal spread all around her neck and the back of her head. So that's what SDC can act like. Way beyond the reach of radiation therapy sometimes. And this is just a review of that. So what is the most commonly involved cranial nerve that should be addressed by either surgery or radiation in case of a deep lobe parotid cancer? And we talked about how there can be nerve spread, and that the anatomy of the parotid is defined by the passage of a nerve that goes right between the superficial and deep lobes, and also that there are certain nerves that run along the floor of the mouth that should be controlled if you're dealing with a sublingual or submandibular gland cancer. And there are also nerves that obviously have a long track through the neck. Okay, I thought that was, oh yeah. Well, it's fair to talk about trigeminal because in cases of a very extensive minor perineural invasion within the tumors, we talk about prophylaxing up to the pterygopalatine fossa and pterygoid region just as from the floor of the mouth if it's very, very extensive. But that's not what you would be concerned about for a deep parotid lobe. And the what I call the intersectionality between cranial nerve 7 and cranial nerve 5, I have not seen that happen in a parotid gland cancer before. I have seen it happen in squamous cell carcinomas of the skin, which very commonly will have traffic from cranial nerve 7 to cranial nerve 5. And I think we covered all the major points here. Sure. The and the spinal accessory nerve actually. Many of you may know that when a neck dissection is done, the spinal accessory nerve is the cranial nerve that runs through the neck and is the reason for shoulder dysfunction, and that would be involved if you have really, really extravagant neck disease, which we have seen too. That can happen, but only for the neck, not necessarily for the parotid. Okay, in the RTOG randomized study of neutron versus photon radiation for unresectable salivary gland tumors, which of the following is true? This is a little hard at the end of the day here. Okay, so local regional control, was it better or was it worse with neutrons? And then was that result negated or altered by the finding of distant metastases in this trial, which overpowered any advantage that might have occurred? And that gets to the overall survival question. So we're talking about both of them being superior with neutrons, just the survival being superior with neutrons, just the local regional control rate being superior with neutrons, both distant and overall survival superior with neutrons, or all control locally and distant being superior with neutrons. You can start the counter. So just remember that neutrons was considered valuable because of its high LET. And then in the trial itself, what ended up happening was there were a lot of other factors that played into survival. Oh, I pushed it afterwards and it still turned green. Anyway, okay, great. Yeah, so the overall survival wasn't superior because distant metastases came in and sort of wiped out that initial promising local control with the neutrons. So there was a 10-year update, which we can talk about. The 10-year update actually confirmed that local regional control remained higher among the neutron-treated patients, but there was still no overall improvement in survival. And distant metastases accounted for the majority of first failures on the neutron arm because they were controlled a little bit better versus local regional failures were the majority of failures on the photon arm, but remember then the photon arm you had a lot of squamous cell carcinomas, which were challenging. And long-term morbidity was severe on the neutron arm at a higher rate. Okay, and then here we'll get into the target therapy a little bit. What should be the first-line systemic therapy for HER2 negative, androgen receptor positive salivary ductal carcinoma? So there's cisplatin gemcitabine, which is a chemotherapy, lenvatinib or Lenvima, and entrectinib, which is a TRK inhibitor, TRK, NTRK, trastuzumab, which is a HER2 targeted therapy, and leuprolide or Lupron, which many of you may know. So if this patient had been HER2 positive, androgen receptor positive, I think you decide based on how urgent the patient's situation is and what you want to go with in terms of the highest response rate. In a patient who's HER2 negative, androgen receptor positive, it's pretty clear that you would want to go with leuprolide. Lenvima or lenvatinib, as we talked about, has shown efficacy against adenoid cystic carcinoma, but this was a salivary ductal carcinoma, the really aggressive type. So the thing to keep in mind is targeted therapy looks promising against adenoid cystic carcinomas. Hormonal manipulation looks promising against salivary duct carcinomas. Salivary duct carcinomas sometimes have an appearance almost like an adenocarcinoma of the breast. Their histologic appearance can be very similar, and that's part of the whole gestalt of this. Questions? Are any of you guys using hormone therapy? And it sounds like someone was back there. Yeah. I think this is going to come into the local regionally advanced setting pretty soon. And it'll be interesting because as head and neck radiation oncologists, we never used to have decision-making, long conversations with patients, but now we do because of HPV. And we never used to have hormone therapy conversations with patients, but now we do because of salivary ducts. So it's like I've become a prostate cancer doctor. Thanks.
So thank you, everyone. So we're rounding up our day, and our next doctor is where we all want to be, probably as soon as we can. So Dr. Arav Gillette is going to give a talk on retirement and even things that you need to think about if retirement feels like it's far in the future. So a really interesting talk. He retired and then discovered all these things that he wished he had known. So he actually did internal medicine first at Cornell, and then he did medical oncology at Johns Hopkins, followed by radiation oncology at Johns Hopkins, and then did a brachytherapy fellowship at Vanderbilt. And he's been very involved in ACRO and nationally, and is really a model to us all, and is here, even though he's retired, and we appreciate for him to be here and to teach us what we need to know. So Dr. Arav Gillette.
Very good news. is that there's no Sam in this. So you can listen to what you want to listen to and ignore the rest. What this is this is really a personal, a rendition on a personal journey. And I'll also tell you that when I was asked to do this talk, I prepared this talk about 8 months ago, and it seems like almost every month something has come up that has made me want to change it. So if you ask me in another 2 months, you'll probably get a slightly different talk. Anyway, I'd like to talk to you about preparing for retirement, some of the things that you might think of, some of the things that might be of interest to you. This actually was part of a slide show that I heard in 1998, and at that time, I was a little bit incredulous. And the caption is, this is neither heaven nor hell, it is the private sector. And I don't think anybody would disagree with that now, even those of you in academic medicine. Some of the items that I will cover, slowing down before retirement, what benefits you're losing from your employer. I'll talk a little bit about employer-sponsored health insurance. You usually get health, dental, optical. You know, their prescription plans. You get business deductions, access to medical care. Do you have a plan after you retire? Are you going to do consulting or locums? And some income tax implications of forming an LLC. What I will not discuss, but it certainly needs prior preparation because I can't even begin to tell you that I know enough here, and that will be Social Security, when to take it. I will tell you some of the ins and outs. Defined benefit plans, KEHO, 401k, KEHO and 401k catch-ups, annuities, life insurance, and then wills and trusts. How many of you are over 60 in this group? Raise your hand. Okay, so I see at least a number of, and by the way, I'm very pleased to see that this will be the third Hawaii meeting that I've had the opportunity to attend, and this is the youngest crowd by a wide margin. So I'm very pleased that the younger members of our specialty are getting what I believe is smarter, and they realize how important it is to stay absolutely on top of things. So anyway, if the people that should really be learning about this is your 65th birthday coming up? Do you intend to work beyond 65 in a job that provides health insurance, and you're not sure whether or not you should join Medicare? If you're 65, you automatically, unless you choose not to, are enrolled in Medicare Part A. And in this group, I don't have to explain what Medicare Part A is. But there's some things that you can help to troubleshoot. And is health insurance available from your previous employer? I happen to have a friend who's in a law group, and his particular group, even after he retires, provides him health insurance. So it's whatever you negotiate or is negotiated for you. Also, now that you're retired and you have a little bit of time, would you like to travel abroad for an extended period? Or even would you like to take a number of bucket list trips? There are a few assumptions that I've made for this talk. First of all, I'm only going to talk about traditional Medicare. Those of you who are in practice, and I'm sure quite every one of you, have formed an opinion about Medicare Advantage plans. Bottom line is, you get what you pay for. And I'll just leave it at that. There are a number of disadvantages for Medicare. First of all, and the biggest one probably is that if your wife or your spouse or your significant other is less than 65, you can't do it together. You'll have to find different insurance for that patient. And I'm currently an aging jock, and I have a bunch of guys that have married younger spouses. And that is their single biggest problem, is how do I find insurance for my younger spouse, because individual plans in most states that are of any value have skyrocketed and tripled in monthly cost. Now, I guess the question you need to ask yourself, are you financially stable? Is the retiring optional? Well, you know, that's something you probably are figuring out as we speak. Ever since 2003 or 4, used to there was one fee for Medicare. Now there are 3 tiers, and I'm pretty sure everyone in this room, unless you're completely retired and doing absolutely nothing, is going to pay the top tier. If you and your spouse are both paying Medicare in the top tier of expense or cost for Medicare Part B, you'll pay about as much as you did for a high-quality private employer-based health insurance plan. I believe I currently pay $465 a month for myself and my wife. As I said, I'm not going to consider the Advantage plans, Medicare Part C, PPOs, PSOs, or HMOs. Again, this is my opinion. You will need obviously Part B, the supplemental, and Part D. If you do not get either one of those, you will not have any of the advantages of large group negotiation benefits. I'm also assuming that you will reside primarily in the United States. If you plan to be an expat and live in Paris or Scotland or Ireland, then you may be very fortunate and be covered under theirs. And that's, again, an individual thing. I remember my father was a West Point graduate, and one of his classmates decided that he wanted to go back and live in Ireland. And he did so, and Ireland not only sent his kids to school for free, but they gave him all the medical care that they had, even though he'd only lived in Ireland for about a year and a half before he started to need, you know, the education benefit and 2 or 3 years. Whether that's the case, you would just simply have to check. Also, I'm assuming that none of you will qualify for low-income or disability assistance, and you also have to have paid into Social Security for more than 40 quarters, which isn't very hard to do. Why should you choose traditional Medicare? Well, there are no pre-existing issues and exclusions, and as you know, one of the things that our current government would like to do is to change that a little bit. It also has the fewest limits on diagnostic testing and medicines. I'm quite sure that all of you have had the opportunity to fight with a particular insurance carrier because you wanted a test for your patient that was not on the covered list. Medicare doesn't do that. There is automatic re-enrollment. You don't have to worry about all of a sudden, whoops, you know, I didn't meet my employer's 6-week date from the middle of October to the beginning of November or whatever it was. Now, you can change policies, but if you don't change policies, you're automatically re-enrolled in the one you currently have. And there are no limits on coverage, which I'm sure that all of you have already found out in some of your practices. Now, what won't Medicare do? Well, I've already talked about how you'll pay. It doesn't cover your dependents. There's no insurance for dental, ophthalmology, or foot care, or optometry is really what it should be. For instance, if you get cataracts, they'll take out your cataract, but they won't pay for your lens. So, you know, if you want to wear glasses that look like Coke bottles, you can, and it won't cost you a dime. But, you know, if you want a lens implant, then that's not covered. Pregnancy isn't covered, and child care isn't covered. So what type, assuming that you have gone the way that I have chosen to go, what type of insurance? Well, for Medicare Part A, you must sign up at age 65. If you don't, there's a significant headache in getting yourself signed up. It is offered, as I say, free. It covers all your hospital costs. There is a deductible of $1,316 for each 60-day hospital benefit period. But if you have to stay more than 60 days, that goes away. It doesn't cover long-term nursing costs. And I'm sure you all are familiar with trying to keep your patients in a SNF or an LTAC versus a nursing home. If you're not indigent, you don't qualify. If you all were on Medicaid, you would have a significant benefit here. It is automatically incorporated into your employer-based insurance, so that's probably why, if you're over 65, you were able to continue working and you didn't find that your insurance premium changed. What does it cover? It covers other services provided directly by the hospital or nursing facility, lab tests, prescription drugs, medical appliances, supplies that happen in the hospital or when you were being covered by Part A. If you're an outpatient, then you need Part D. All services provided by a home health care agency if you qualify for continuing home health care. Now, Medicare Part B, again, we have a pretty rough idea of what all of it is. It covers some inpatient 23-hour and outpatient 24-hour observation. All diagnostic and lab tests done in outside facilities that accept Medicare, which is virtually everyone. Medicare supplemental required for the additional 20%. There's some inpatient prescription drugs that you get while you're being covered by Part B, and it's sufficiently complicated that I have to read the paragraph 3 or 4 times, and then I remember it for about a minute and a half. It does cover some physical, occupational, and speech therapies and outpatient mental health care. It does not have the strict limits that your employer-based care did, unless you have additional supplemental purchase with the employer, and sometimes that isn't even available. It does cover emergent ambulance and rescue services. So if you want to take the ambulance to the ER, for your cold, you can, and I'm sure you've seen more than one of your patients who has done that. There is a monthly fee based on the last 2 years' W-2 form. If you can, and this is where very, very complicated financial planning and that also takes time to do. If you can actually get your income underneath a certain level of $84,999, then your monthly premium goes down drastically to $135 a month, again, for you and your spouse. And if you're on Medicaid, then that all goes away. You don't need to sign up for Medicare Part B until you retire, but you have to prove that you've maintained insurance. Otherwise, you are subject to a penalty. Now, in my own personal life, I decided to retire at the end of February. The open enrollment period stops in the middle of December. And since I did not make the open enrollment period, where I would have had to pay double for 3 months, I had to prove with a special form that I was employed. I will tell you, it took me 6 months to get that straight, and 4 visits to my employer because they kept losing the form. I emailed it, I faxed it, I sent it certified mail, and then 2 weeks later, in the mail, I would get something that said, you're subject to the penalty and you need to pay it, otherwise you will lose your Medicare Part D coverage. And then, of course, if you lose it, you then have to reapply and you get subject to the penalty. So I would suggest that either you not go anywhere for the first 2 or 3 months before you, or right after you retire, or that you have somebody that picks up your mail, because they will not email you. They will not answer the phone. Or if they do answer the phone, it doesn't count. If it isn't a piece of paper in your hand, it doesn't exist. A form, is here, and you can look that up. In fact, I think this is so important that I'm going to make an extra slide to say this all over again. This caused me more headache for the first 6 months of my retirement than everything else. And I finally got it solved, I think. I haven't really had to use it. Types of Medicare Part B plans, they vary by state, by zip code, and county. So you can't just look up, I'm from Texas, you can't just look up Blue Cross Blue Shield of Texas and expect that if you live in Lubbock or Laredo, you're going to have exactly the same thing that is offered in Dallas. Now, for traditional Medicare, there are A supplemental plans. There is A, B, C, F, K, L, and I'm sorry, there's one more, there's G. Again, it varies by state, and doesn't work if you're under 65, and it doesn't work if you can't get Medicare Part B unless you've gotten Medicare Part A. The Advantage plans, they do cover, wellness, vision, dental, perhaps your subscription to Lifetime Fitness. But if you ever really get sick, and I'm sure all of you have had the opportunity, to witness that on one of your patients. I don't need to go over the Part B services. Even I won't remember this this afternoon. And also what it covers. Medicare Part D, if you remember, George Bush defined this in the second term of his presidency. It is a private health insurance plan. It follows the rules of private health insurance plans. Those companies are here to make a profit. They are not here to give you a benefit unless they can make a profit. You must sign up for it when Part B is applied for, or additional penalties will apply. And that also took me about the same 6 months to get sorted out. There are 3 basic categories: basic, intermediate, and comprehensive. All of them have limitations. For instance, in Texas, for instance, Mutual of Omaha was trying to get into the market. So their Part D program was dramatically cheaper. And when you call up to sign up for Part D, you really have the experience of someone who is a marketer. You get someone that is busy trying to push you into one program or another. And because they get paid a differential amount. Blue Cross Blue Shield of Texas pays a good deal less than Mutual of Omaha. And you will, and even your state medical society, if you belong to your state medical society, they often give you a number of different options. But that's really, it isn't the state medical society, it's the state medical society has been provided with various contractors that are paid on commission. And so, it's caveat emptor no matter how you look at it. Prescription drugs, Medicare Part D, I've talked about is private insurance, what's covered. Prescription drugs on approved plans and on the formulary of the insurer. Now the formularies change from year to year, and Mutual of Omaha is different than Aetna, is different than Blue Cross Blue Shield. Blue Cross Blue Shield has a different formulary in Texas than it does in Louisiana. Now, it may be a little bit more closely related, the one that is in Louisiana, Texas and Louisiana, than perhaps in Maine, but not necessarily. It's whatever, the various Blue Cross Blue Shields. And, as somebody who is still involved in ACRO and some of the insurance issues, the Blue Cross group states that they have no relationship, one state versus another. And so do all the rest of them. I will tell you as a provider of oncology services, Blue Cross Blue Shield did more things to make your life miserable than just about any other insurer. I mean, it was a close race, but Blue Cross Blue Shield won the gold. As a patient, from my vast experience of 9 months, Blue Cross Blue Shield probably is better to patients than anybody else. Why? Because there are millions of patients. What are there, 4,000 of us? They know their market. Okay, I've talked about the 4 plans. There's something called tier jump if you have a comprehensive plan. Oh, and I'd originally said there were 3 plans. There were actually 4, and that is it's actually a supplemental to Part D. It isn't part of Part D. There's something called tier jump, and with each one of these plans, there is a spend down. So, for instance, looking at me, you can see that I can't go out in the sun without getting a skin cancer, even though I haven't been in the sun since I was 25 years old. If I'd have gotten a set of medicines that I put on my face, 5-FU and a vitamin D analog, I would have paid about $500 for it in December. And then if I waited until January, and by the way, I went to see my dermatologist in December, and he said, you've got all kinds of pre-malignant things. And if you want to look at me closely in bright light or a woods light, you might see a few. And by waiting till January, I was able to get most of my spend down done, even though both of the things I had are generic. Let's see. Some issues with Part D. We talked about its prior insurance. Higher incomes pay more like Part B. Each insurer covers different drugs. If you're on a chronic drug, please take a look at it. One of the things that I've done is to quiz physicians who I respect and who I think are very smart, who have been retired for a year or 2 or 3, because there's nothing like a little personal experience, just like we have these outstanding presenters here giving you their personal experience, in particular diseases. So if you're on a chronic med, make sure that it's covered, because if it's not covered, it can be very, very expensive. I'm a particular nut about making sure that I don't get a DVT. One of our past ACRO presidents and one of the shining lights in our specialty, who is still very much contributing to the specialty, ran all over the place on airplanes when he was in his early 40s. He got a DVT. He was on 10 years of anticoagulation, finally went off of it, and within 2 months was on an airplane again and got a pulmonary embolus. So if you're going to, you know, let your heart soar and spend a lot of time with your legs, you know, underneath your airplane seat, or be terribly sedentary, think about what you need to do. My wife and I had to get Xarelto. I paid $25 a pill for Xarelto because which I just got, and you know, I need 10 pills for this year. And I even bought my wife's. One of the advantages of maintaining your license is that a great many pharmacies will let you write your own prescription. And so I, you know, rather than go and wait in line, I wrote my own prescription for Xarelto. But I spent huge amounts of money. Whereas had I gone through my spend down and, you know, had a top tier drug, I would have only spent $30 a month for Xarelto for the entire year. The other thing is you notice that from one year to the next, different drugs come and go. You know, I tried to use Fragmin. You know, you may remember that's the low molecular weight that you inject sub-Q, because that's been around for a gazillion years, but I couldn't. They don't make Fragmin anymore. There's no profit in Fragmin. So none of the none of the pharmaceuticals make it. You can't get it. You can get it in Canada, but you can't get it here. Okay, Part D, carrier-imposed limits, authorization, quantity limits, step therapy. In other words, if you have a seizure disorder, and you know, your insurance might say, well, you know, phenobarb and Dilantin are the way you need to go. Well, maybe that's not your best drug. It helps if you have a reaction to Dilantin, or if you have a better insurance plan that you can go on to something that has fewer side effects. But side effects are not the insurance company's problem. You may need to try alternate plans. We've talked about how often they switch. You can request a coverage determination, but it's a special form and you have 72 hours to respond. And it can be denied, but you know, again, you then have to go through the mill one more time. Some of you may have heard of the donut hole, and it begins when you've hit the limit of initial coverage and ends when the amount you've spent out of pocket hits another dollar limit. And I'll have a graphic that I have to look at for 20 minutes before I understand it, and I won't, you know, and I do it each time. Medigap policies. Medigap is extra insurance that you buy from a private company to pay for your health care costs, such as deductibles, co-payments. Important if you travel outside the United States. I'm going to go to, well, it's Israel, but I'm going to go to Jerusalem, and probably not Bethlehem, because those are, you know, one is in the Israeli controlled, and let's say I need some important emergent medicine, or I need some important emergent medical care. I'm not covered if I travel there. Now, most private insurances or employer-based will cover you. So if you're employed, you know, and you want to go to Tel Aviv to give a lecture, you're covered. There are various levels. I actually looked it up last night, and for me to get coverage up to $500,000, I pay $4 a day, and I have to do it for a minimum of a week. So if you're a belt and suspenders person like I am, you know, I'm going to pay the $4.50. Another option, and American Express offered this last year, I haven't looked, but certain high-end cards that charge you a fee each year will automatically guarantee you air ambulance from wherever you are back to wherever you want to go. I don't happen to have that. Here's the donut hole, and I'm not going to take this group's valuable time to explain it, other than to say that there's a coverage gap that either you'll pay for or you'll buy insurance from. More about the donut hole. All Part D enrollees are eligible for discounts if they fall into the gap, with the exception of those receiving extra help, because they're already covered. Some restrictions apply, and if your Part D plan already gives you some coverage for your drugs in the gap, your plan's coverage is applied first and then the discounts. I will also tell you that if you, for instance, last year I didn't really have I'm not on any medicines chronically, and I wanted to get some things, and so I got online and I found a drug company discount. Essentially, it's a rebate. And I was able to get the drug for about a third of what the list price is. It's kind of like the fees that we all charge. There's the list fee, and then there's what we really get paid. Vaccines, Part B pays for pneumonia, hepatitis, and the flu. Part D pays for shingles. I happened to, at my wife's urging, get a tetanus shot, and I've got all kinds of coverage. At Costco yesterday, I paid $55 for a tetanus shot. Tetanus shots used to be nothing. And that has to do with, again, what's been negotiated and what your plan offers. What Part B doesn't cover, you have to pay the whole tab for drugs that are not on the approved list. And again, you have to look and see what market you're including yourself in. I will even tell you that I paid less for 5-FU cream, which has been around since I believe the early 1950s. Now that I'm in Medicare, because more people are needing it, than I did when I had US Oncology employer-based insurance. They wanted $350 for a tube. I ended up getting it in Canada for $50. And I'll talk more about using Canada for drugs. What Part B does not pay for by law, over-the-counters, drugs used for anorexia, weight loss, or weight gain, and like most things, that's kind of fluid. Drugs used for cosmetic reasons or hair growth, drugs used to promote fertility, drugs used to treat sexual or erectile dysfunction. Well, don't you know that the drug company was thrilled when Cialis had a BPH indication? Medicines not used for cough or cold symptoms, prescriptions, or drugs or mineral products. Also doesn't pay for services abroad or acupuncture. There are a number of preventive services, and I'm not even going to try to list all these. You need to take a look at them yourself, and besides, the print is way too small. I merely listed them so that you know that it's there and you can take a look at it. What Medicare limits, length of hospital stay, more than 90 days per visit. They'll charge you a copay. We've talked about that. There's a concept of lifetime reserve days. If you want to go to the hospital, or if you end up getting admitted repeatedly, you can stay 90 days, but you have to be discharged. If for some reason you're so sick and you still can't, you can get an extra 60 days, but once you've used up that lifetime benefit, you better, you can't get Medicare to cover your cost if you're on death's door and required to, or need to stay in the hospital more than the 60 days. It does take care of some skilled nursing facility stays, some SNFs, some mental health benefits. Actually, they're some of the best that you can get. Those of you that have had dependents, that you've had to pay for mental health care coverage for this, that, or the other thing, then you're aware of the limits of primetime coverage. And of course, there are limits on occupational and physical therapy. But each one of them restarts the moment you have a new problem. The source for this was the Dallas Morning News. You know, there are a number of places around the world that will, you know, you can send it to Mexico, you can send it to Canada. This is the one that I have used. It's called U-Drugstore. And they make it very, very easy. You get on the internet, and unlike current US policy where you don't know what a drug is going to cost you until you go to pick it up having had the prescription, you can actually look this up and they will tell you ahead of time before you even send in the prescription. Now the caveat is if you're a physician, you can't write your own prescriptions. You have to get your partner, your family doctor, someone else, some other physician to write your prescriptions. When I retired, I got a whole book of prescriptions that were signed by each of my partners, and they're still speaking to me. There's, you know, and I'll put the date on. Now, obviously, no Schedule 1, no Schedule 2, and no Schedule 3. And I guess there's a fair amount. One, you know, the U-Drugstore. And interestingly enough, I went Nordic skiing in Canada last February, and a friend of mine has, unfortunately, medical school friend of mine, he also retired, has 3 kids that are significantly challenged that are on seizure medicine. U-Drugstore isn't available to him in Canada. I tried to get on the internet to show him how wonderful it was, and Canadian internet won't connect you. He had to go back to Michigan, which is where I went to medical school, to get on their internet and, you know, their IP provider. Private health insurance, there's always private health insurance, and if you're wealthy enough, you can have that. I would recommend these 2 books as good sources of information. I would recommend that you speak with your financial planner, your tax advisor, your accountant for the others. These Medicare for Dummies books are updated every 2 to 3 years. You can get them at Amazon. You can even get them in an electronic form. I love the electronic form because it allows you textual search, and you can find what you're looking for. We've already talked about when to enroll. Open enrollment, if you are going to be signing up, is October 15th to December 7th. If you decide that you don't like it, you want to change something, or you want to disenroll, it's January 1st to February 14th. We've talked about automatic renewals. None of those things are available in private health insurance. Special enrollment periods, I've already spoken about the headaches that I personally had to do. When to retire? Well, you know, part of the reason that I retired in the end of February was that my employer had a pre-tax benefit of $2,500 that I could use to spend on anything. Eyeglasses, dental care, foot care, anything. And my wife and I, in the space of 2 months, you know, it's not amortized over a year, it's $2,500. So we were busy getting crowns and all of our dental work done. And I can assure you that your dentist, when you go back, and our teeth cleaned. For instance, now I get my teeth cleaned, it used to be free. Now, at least my particular dentist, who will see anybody, anywhere, anytime, even on weekends, charged me $180 to get my teeth cleaned. And I actually had less done than I did when I had medical insurance. I didn't even get any x-rays. I just had somebody sit there and, you know, scrape the plaque off. You can use it for dental, eyeglasses. It goes from calendar year to calendar year. But I would recommend, if you are smart enough to get past the late enrollment thing and persistent enough that you maybe retire in January. Then you can spend the whole $2,500 for you and your family or your spouse over 1 month. I've already talked about how different plans pay wildly differently, and it isn't just for us, it's for everybody. My son-in-law took a job, he was in Colorado working for oil and gas. He took a job in Dallas. So for a period of about a week, he had no insurance. And he had gout. So I looked around trying to prescribe colchicine for his gout. And I ended up spending, and those of you that have done, ever treated gout, you basically give the colchicine 4 or 5 or 6 doses until you have GI upset, and then you quit. Or you can use indomethacin. I paid $50 a pill for 4 pills. You used to be able to get it for a nickel a pill. Medicine's been around 70 years. And here's just, a various, a listing of what you drugstore with coupons, so there are many, many different things. So here, I've already complained to you about, all of my various Medicare travails. And this is the sort of letter you get. And this talks about how the payment is figured, the last 2 years of income. If you're really smart, and for instance, annuities are not counted as income. If you want to put all of your money in an annuity, you can make $25,000 a year of taxable income. The super rich, and I don't know how many of you have seen on Netflix Hassan Minhaj. He did a wonderful thing on tax a month or 2 ago. There are all sorts of ins and outs, but they take time, they take planning, and they take expertise of somebody who's a lot smarter than I am. Things can come up and bite you. For instance, if you all of a sudden put your IRA, you decided to take distributions, and even though you were only making $100,000, you had $100,000 a year in dividend income that is taxable. And by the way, there are at least 3, and I believe 4 different types of dividend income, depending on how you have set it up. But if you just push your IRA or your KEHO or your 401 and haven't prearranged it as something other than straight income, then you get taxed as income at the income tax level, which is just about double what it is for capital gains and other various vehicles. Okay, I've talked about reducing your out-of-pocket expenses. Talked about Medigap insurance. Don't need to speak about it again. Again, here is another list of the Medigap plans. They're not satisfied with an A through G. They now have A through N, because obviously you need more flexibility. I've also talked about, this was actually an article in the Dallas Morning News about 2 months ago, about not auto-renewing if you're on a chronic set of meds. In my discussions with a series of physicians that are on chronic meds that have been retired, I still think Blue Cross Blue Shield, at least for Texas, is better than most. But, again, check out your plan where you live. And as you might imagine, there are a number of prescription plans. This is a comprehensive list of prescription plans available for people that live in the Dallas area. It might even be a little different if you live in Lubbock. You all probably all know about COBRA. If you're changing jobs and you need to, take a little time or whatever, you already have gotten Cobra. The nice thing about Cobra is it's wonderful short-term insurance. Everybody gets it. It covers everybody, you know, you, your children, your spouse. You're not paying individually, but it's very expensive. And Cobra stands for Consolidated Omnibus Budget Reconciliation Act of 1986. So if you think the acronyms for radiation oncology trials is onerous, go to the federal government. Here's what it's for. So summary on healthcare plans. This has been a personal journey. Now I'm going to talk about how to position yourself and keep a small job or do locums. And there's some advantages to that. You can form an LLC, you can take distributions, all of your income is not automatically taxed at your income level rate. So let's say that you have a lifestyle that requires that you make or that you have $150,000 a year to maintain the kind of lifestyle you either have or you want to have. You can, well, first of all, you can make some income with that. But if you just do locums and take it as income, the money that you make as that will go directly, you'll pay the income tax rate, which, depending on the state you live in, depending on a number of other things, can be as high as, in the between 30 and 40% or even a little bit higher. You have to set it up with accountant. You have to get a tax ID. Well, the tax ID takes 48 hours. I can't remember how much it cost, but I don't think it was more than about $150. Your accountant sets it up for you. You keep your income statements entirely separated. You may even get a home office exemption. I have a study that I do virtually nothing else than put together this talk, do a little bit of locums for Texas Oncology, and do a little bit of consulting for Texas Oncology through my experiences with ACRO. And all of those things are now in my LLC. You can write off your cell phone, pay your internet bills. You obviously have to bundle or, separate that from, the sports network or whatever else you do. Other expenses as reviewed by your accountant. Now, when is the best time to negotiate this with your group? And I will tell you, in this cartoon, again, this is a 20-year-old cartoon. It says, "I'll level with you, Charlie. I'm going to let money get in the way of our friendship." And it just is true. What is there to know about locums jobs? Well, those of you that are anywhere near my age, and probably some younger ones of you who didn't, and I'm assuming that nobody here is a resident who's using locums as a way to find an experience and find a permanent job. They're too numerous to count numbers of companies. CompHealth is probably the largest in our specialty. Frankly, one of the things that I would like ACRO to do, but we don't do it now, is I would like ACRO and its experience in accrediting practices to accredit physicians, because I think that, there's a premium to be made on a physician that actually knows what he or she is doing. We don't have that yet, but the kind of flexibility that ACRO has, that might be something that we can offer in the future. And don't you think that that would increase your saleability? Because when you go and you are a locums person, it's whatever you negotiate. But I will tell you that the locums company, like Las Vegas, the house always wins. They're going, generally, if you pay $2,500 a day for locums, the locums company is keeping $1,000 if they're a generous locums company. They could even keep a little bit more, or they might charge you $3,000. The other thing that the locums company does that really hurts the residents is if you do locums through CompHealth to Texas Oncology, If you join Texas Oncology, either you or Texas Oncology has to buy out your non-compete. And I have some, a couple of sample of non-compete. Now, you can work for, but you all of you in universities, and even, for instance, at UT Southwestern, even the residents have non-competes now. Certainly the junior faculty members all have non-competes. I'm not sure about senior faculty members, and I think, some of the folks here, like Dr. Yam here, could probably say what happens at her university. But what happens at her university has no particular relation to what might happen at Hopkins or, another major university. Okay, we talked about travel, room and board malpractice, other incidental expenses. Now, when you get one of those contracts, I'd read it very carefully. Remember, this contract was written by a lawyer. As many of us as physicians tend to be big picture people, lawyers are not big picture people. They're minutia. And you can find yourself unpleasantly surprised. This one says, ha ha ha, Biff, guess what? After we go to the drugstore and the post office, I'm going to the vets to get tutored. What are the other options? And I actually want to thank Ted Yeager for alerting me to this at last year's ACRO meeting. We had a kind of a lunch ad hoc meeting of all those people that were thinking about retiring and what could they do. And you can have private contracts with separate facilities. I currently have a private contract with Texas Oncology. It pays me about less than a third of what I used to make per hour when I was a partner. And I didn't even have a particularly rich practice. So had I had a rich practice, it would probably be a fourth or maybe even a fifth. But I have no malpractice. I show, once I agree to do a day or 2 days or 3 days, I do it. I get a check in the mail, or I get it wired into my bank account. And depending on how much you want to work, how long you want to work, if you want to just do 1 or 2 days, it's not work. Somebody only wants you for 1 or 2 days, which is what Texas Oncology often does because they have a lot of single physician centers. If you're in a large multi-physician practice, they probably won't even want you for locums because they don't have supervision issues and they'll just have the partner cover. Locums in medical oncology in most even medium or even small facilities is really not an issue because your partner sees those patients, your partner bills. For radiation, since there are many, many fewer of us, if you're in a single doctor facility, you probably have had to use locums unless you never wanted a life or never wanted a vacation. And everything is negotiable. If you have special expertise, brachytherapy, SRS, SABR, SBRT, that can improve your compensation. Ted Yeager does a bunch of work. He retired. He was a number of places, including Duke, I believe, and in Philadelphia. He retired in Florida, and he has 3 contracts with 1 or 2 groups. He shows up, he does what they ask him to do, they pay him a rate, they cover him on their malpractice policy, which is usually very easy to do. If you don't have some sort of arrangement, then you might have to have your own malpractice. And now I haven't practiced in Florida since 1990, but when I left Florida in 1990, my malpractice, having never been sued, was $120,000 a year, and the tail was even more. I bet you, and there was the neurosurgery compensation fund that you had to pay into because there were so many. So again, it's whatever you negotiate. One thing that I would strongly recommend you all to be thinking about is slowing down before you're retiring. And this was offered to me, and I didn't even really appreciate how wonderful it was before, or when it was offered to me. Texas Oncology, I had, the advantage of giving people notice that you're going to retire is that they have time to bring somebody on, they have time to get them up to speed, they have time to do what they need to do. The disadvantage is if they want to get rid of you, Texas Oncology has a 8-week clause that they can, I'm blocking on the language, but basically they can dissociate themselves with you with 8 weeks notice, and you can dissociate yourself with 8 weeks notice. So if you don't trust your company, maybe you don't want to do that. But, people were very good to me. And I had for 18 months a physician that worked side by side, and the two of us split a single practice. And it was wonderful. You have to work about at least 50% at time. And those of you that have had to deal with getting on insurance plans, it took him 5 months of hard work and to get on an insurance plan. So I was seeing all these patients that he didn't, he wasn't on the insurance plan to see. But after that first 5 months, I took a pile of vacation. And I only worked 2.5 days a week. I ended up having to get an artificial knee about 1.5 years ago. My aging job caught up with me. And I was able to take 2 months off and rehab it to the nth degree because somebody was doing my work for me, and I still got paid. I will tell you the last year of my career, because my company treated me well, I made about as much money being there half the time, taking all kinds of vacation, as I did when I was working very, very hard and taking no vacation. So, but the moral of that story is you need time to develop. If you've been working 60, 70 hours a week, you've been in there on the weekends, you've worked some nights, or at least long hours, it takes you a while to find out, or either to remember what your interests are, to develop what your interests are, to have time to develop relationships that you want to. And, as my wife looked at me and said, Arv, I've been waiting for you for 40 years. I'd kind of like to get to know you. And I hope I'm doing a good job. We'll see. She's here. But the other thing is using medical staff benefits from your old hospital. I have since took me a while to figure out what I wanted to do. I wasn't as smart as people like Dr. Umami, who knew he wanted to be a radiation oncologist from day one. Took me, an extra 6 or 7 years to figure out where I needed to be. But, I have a little practice on the side. I don't charge for it, but I have a whole group that is busy asking me, well, gee, Arv, I've got my aging father is a little demented, and he's got a single, high anaplastic rib lesion. How should we deal with it? And you'll find that unless you have no desire to be, enter into that, you will have unlimited number of people that want the free advice. But if you're going to do that, you need to, for instance, get up, or if you've been in the hospital or at US Oncology, up to date. I'm sure, is there anybody who hasn't used up to date in this room? I didn't think so. I get up to date for free because I have courtesy medical privileges from my old hospital. I've done 1 locums day for them in the last 18 months, or the last 11 months. But I'm on courtesy medical staff, so I don't have to attend the Department of Medicine meetings. I don't have to attend the hospital general meetings. And since I live in Texas and they don't think very highly of us, we have to get an ethics course. I had a nice lunch and a 2-hour ethics lecture, and they kept track of my CME. I did that a week ago, or 2 weeks ago Tuesday. And I went by the department and shook everybody's hand and said hi. It was lovely. But you can use the, and you can, if you want library searches, that's all part of what they do. Even if it has absolutely nothing to do with what your particular specialty is. Okay, I've already talked about how plans change from year to year. Some people worry about, do you accept medical care, or do you accept Medicare? If you're a physician, first of all, almost everybody accepts it. And second of all, I'm sure you have a personal relationship with somebody who doesn't accept Medicare, who will be pleased to see you. There's a basic drug list that is specific to each Part D insurer-sponsored program. And it's 87 pages long with multiple columns. Check that before you decide what you want to do. And finally, I don't think you should worry about whether you're going to be bored. There is not a one of you, even the youngsters in this room, who hasn't changed what they do every 2, 3, 4, 5 years. I mean, when I got into the specialty, we used skin marks. We did, X-ray simulations. You wouldn't do that now. We did hot loading. God knows how much, with the long-term effects, although I don't think they're much, of all the hot loading that I used to do. I used to treat skin cancers, that recurrent, Alvaro Martinez's way that he imaged in 1975 with iodine seed implants implanted in the scalp or implanted underneath. I used to make a template on saran wrap, and then I would give roughly 12,000 rads of iodine. I used to use my spent prostate seeds for it, because obviously once you put the seed in, you can't very well take it out easily. So don't worry about whether you will be bored. If you, and I'm sure all of you, have all had to reinvent yourself, with a little bit of preparation, you will have no trouble doing it again. And finally, for those of you that tuned out, this says, I really enjoyed your presentation. During the 3rd hour, my spirit left my body and went to the beach. Thank you very much.